Test. Check, 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 check. Check. 1, 1, 2. Check. 1, 1, 2. Check. 12:34 ஆயிடுச்சா? Check, check. Time. அதில் 54 ஆயிருக்கா? Check, check, check. Check. ஏறுதுண்ணா. Check, 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 check. நீங்கள் ஹெட்ஃபோனில் பாருங்கள். Check, 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 check. 1, 1, 2. உங்களுக்கு வருதா? ஹெட்ஃபோனில் வருதா? Check, 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 check. 1. Check, check, check. 1, 1, 2, 1, 2. Check, check, check. Check, 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 check.
Dr. Anil Kumar, I'm just giving you a prompt to become a panelist. Please accept it.
Background option is there? No, I can blur my background, no? Okay, let me just...
Anil sir, good evening.
Sir, you're muted. Actually, I've muted you. Please unmute.
I'm there.
Sir, good evening. Deepak here.
Hi. It's been a challenge rushing to finish off the work and come. Okay, I'll remove my and all okay.
You're still in your office?
Yeah, very much. Can you hear me?
Yes, sir. Loud and clear.
Okay. Is this okay? Background is okay, or should you want anything different? I can put some other background.
Sir, I think you have blurred your background, right?
Yeah. That's okay.
That will make you look good, sir. The front face becomes better.
Okay. Thank you. I'm here. Okay.
Welcome, Dr. Bagulian.
Yeah, thank you. Thank you very
And
much.
Dr. Anil Kumar, your co-moderator, is also ready, sir.
Yeah, Dr. Anil,
Good evening,
Dr.
sir.
Deepak.
Nice to see
Bahulin
you
sir,
after
good
some
evening, sir. Good evening, sir.
Good evening. Good evening. Yeah.
So we are at 1 minute to start, Dr. Deepak.
Yes,
And
yes,
we'll start
yes,
with
Anand.
you giving a welcome address, and then you could introduce the moderators.
Certainly. It's only 6:58, right?
Yes, sir. We start sharp at 7.
Okay, certainly.
Still, the smartest is Deepak David.
Sir, thank you so much.
It has to be. Is it not, Anil?
I know.
Sir, Bahulin sir, your lighting is perfect, sir.
Oh, thank you. Okay.
You look like the Oscar presenter.
Sir, you mean I'm going to be slapped by others?
No. That will be an excuse. That won't be there.
So, Deepak, you will be announcing the programs, and then
Yeah.
calling the
Yes, sir.
speakers.
Yes, sir. I'll introduce, and then, sir, you both can take over, sir.
Yeah.
The first talk is by who's
So we have a
Sir,
case
sir,
in a
it's
box by
Dr.
Dr.
Suhas.
Suhas.
okay.
So we go live in 1817. I'll tell you. So one request to Bagulian sir, and just to mute yourself for a few minutes, Anil Kumar sir.
Okay.
Till Dr. Deepak introduces the. Thank you. Dr. Suhas has just joined us also. So we go at the count of 3, 2, 1.
Good evening to all of you. I'm indeed privileged to welcome you all to this webinar on Bifurcation Series, which spans over the next 3 days. That's Friday, Saturday, and Sunday. Today, we are trying to talk more on provisional strategy. Tomorrow, we'll be discussing more on decay crush. And finally, on Sunday, on Culotte techniques. Well, today we have the session spanning over 2.5 hours. We start off with the case in the box, which is almost 1 hour duration. We hope that we'll have a lot of discussions during this 1 hour. And subsequently, we'll have a keynote lecture by Dr. Goran, who is a very familiar person to all of us. And over the next over the second session, Dr. Goran will be talking to us on tips and tricks on provisional stenting. And the last 1 hour, we'll have 3 presentations by experts in interventional cardiology. They'll be showing us the challenges that they've gone through during provisional strategy. So that's what we are going to have over the next 2.5 hours. I sincerely pray and hope that we'll have a lot of discussion so that our young colleagues will all be benefited. Well, I'll also take this opportunity to introduce all the moderators as well as expert panel. As moderators, as we have the most senior persons, Bahulin sir, the most lovable person. He was the head of the department of the prestigious Institute of Trivandrum Medical College Cardiology Department. Now he's the head of the department. He's the chairman of Anandapuri Heart Institute. Along with Bahulin sir, we have senior interventional cardiologist, Dr. Anil, a very soft-spoken person in Kerala Cardiology Society. He's actually the head of the department. He's into electrophysiology too. He's at Aster at Kochi. And along with the moderators, we have the expert panel. They are the most hardcore interventional youngsters or even very seniors who's joined us. To start with, we have Dr. Sridhar Kasturi. He's the senior interventional cardiologist and the head of the Department of Cardiology at Sunshine Hospital in Hyderabad. Along with that, we have Dr. Ramdas Naik, the head of the Department of Cardiology at Rajgiri Hospital, Dr. Joby K. Thomas, the senior cardiologist at Caritas Hospital, and Dr. Praveen G.K., the head of the Department of Cardiology at SUT Hospital. And over this, we'll have the case in the box by Dr. Suhas Hardas. He's the head of the Department of Cardiology at Pune. With this short words of introduction, let me hand over the session to Bahulen sir and Dr. Anil. Sir, kindly go ahead with the proceedings. Sir, I think you're muted, sir.
Thank you very much for your kind words, and then we are really glad to take part in this wonderful meeting during the next 3 days' time. I'm happy to chair this session or moderate this session with Dr. Anil, who is a close friend of mine, and pleased to have so many friends, excellent interventional cardiologists, to discuss on this topic of provisional stenting today. We will invite Dr. Suhas to go ahead with his live in box case on provisional stenting. Dr. Suhas, please.
Dr. Suhas, could you unmute yourself, please?
Yeah, done. Yes.
Dr. Suhas, could you just stop sharing for a second? Could you please stop sharing for a second? Dr. Suhas, can you hear us?
Before doing that, I have with me assisting us.
Not audible.
No, sir. No, sir. Dr. Suhas, can you hear us? He is not able to hear us also. He has not shared the computer audio. I'm trying to call him, sir.
Yeah.
आपने म्यूट ही नहीं किया, अनम्यूट नहीं किया।
So it's not seen?
Sir, आवाज नहीं आ रही. They are not able to hear anything. इसमें डालिए, हाँ.
But password किसे का बोल रही है? Password क्या है उसका?
Dr. Suhas, can you hear us? Dr. Suhas?
I think they are not able to hear us.
I'll just stop sharing, sir. 1 minute. I'll just show my face so that he knows we are talking to him. Dr. Suhas, can you hear us? Can you hear us? Dr. Suhas, can you hear us? Dr. Suhas, can you hear us? Just
60 seconds I'll
right. Now we are getting your audio. Sir, 1 second, sir. Sir, I am from the technical side. I'll just take you through. Before you share, you have a tick box which says share computer audio. Please tick it before you share the video. Just go to share screen. On the left hand side, you have 2 tick boxes. Share computer audio, optimize video for sharing.
Understood. So tick share sound.
Yes, sir.
And
Perfect.
optimize. Tick both.
Perfect. Perfect.
And then share. Okay.
Yeah, can we go back to the start?
Yes, we will.
And now you can start playing it, sir.
I'm Dr. Suhas.
Perfect.
Am I audible now?
Yes, sir. Perfect. You can mute yourself, sir.
Today's case is about a 54-year-old gentleman who presented initially to the medical facility with a history suggestive of typical angina and ECG and echo evidence of LAD-related ischemia. ECG showed NSTEMI, and he therefore had an angiogram, which we are just about to present you. But before doing that, I have with me Dr. Preeti assisting us with this case. She's an anesthesiologist. Dr. Savant on my right, and we have Eliamma, who is assisting us with this case as well. Now, having done the angiogram, I'm going to play the angiogram for you right from the first loop. We have preferred to take a radial approach, and we will stick to that. We already have a 7F guide in place. We could feel that the arteries were very good sized when we felt the radial, and therefore we decided to put in a 7 French sheath in the radial artery instead of using a sheathless railway access, which sometimes can give you little problem in case you have to change the guides or manipulate the guides too many times, causing the spasm of the artery. So therefore we have preferred a 7 French sheath here. On your screen you can see the first shot in the epicaudal view shows a very roomy and a large clean left main. There is a LAD stenosis starting right from the ostium, and unfortunately there is a scooped plaque from the superior margin of the left main, and I feel that when we do the intracoronary imaging by way of either IVUS or OCT, whatever we prefer to do here, we will probably find that the ostium of the LAD is deceased and that plaque is extending into the distalmost part of the left main. And therefore this discussion whether we should be placing a stent right at the ostium and will that cover that plaque.
Can you hear me, Dr. Bahulian?
Yes,
Am
sir.
I audible?
Yes, sir, you are. Just
Yes.
a second.
Yes,
Moderators, you can take over.
Yeah.
So I have just paused the video here for a second because I was going to ask if you can invite certain comments at this stage about what do panelists, what do the experts feel about the case so far, because I think I am driving that message too much, and I didn't want to drive that message that the plaque in the LAD is extending into the left main. But how many experts think that they would just do an isolated left main, isolated left anterior descending stenting versus a provisional stenting, a side branch provisional stenting?
Bahulin sir, Dr. Go, Bahulin sir.
Please to discuss that point. I would certainly consider stenting it from left main to LAD, especially once I see that the lesion starts exactly from the ostium, and most of the time the plaque extends from the distal mainstem to the ostium. Well, in all such cases, I usually use the imaging. either intravascular ultrasound or OCT. Usually in my case of left main, if I am stenting it, I prefer to use intravascular ultrasound, and I would look at the plaque burden at the distal main stem. And I am justified in treating it from left main to LAD, especially when you see a plaque in the distal part of the left main. So I would consider stenting it from left main to LAD in such situations. Well, you can consider pinning down to left anterior descending ostium, provided there is no plaque at all in the left main, which is very unusual. And the angle, bifurcation angle, is quite wide. In such situations, and the carina is not a vulnerable carina, then one could even consider that point. But most of the cases in such situations, it would be a stenting from left main to LAD.
Dr. Anil,
sir,
can you hear me?
Bahulin sir, sir, Dr. Goran has joined us.
Yes,
After Dr. Anil's comment, we could ask Dr. Goran to join the session.
Yeah, Dr. Goran, welcome to this meeting. Thank you for your presence. Excellent.
Thank you very much. Can I comment also, or I wait?
Yeah, sure.
Yeah, thank you. I really would like only to reiterate what you just discussed about high incidence of plaque extending inside the left main, although angiographically is not visible. In the study of IBUS evaluation, 92% of isolated ostial LAD actually extends the plaque inside the left main. So what European Bifurcation Club recommends in the consensus is to use, as you suggested, image guidance for this specific subset in order to evaluate plaque composition and distribution, vessel size, because strategy is provisional from the left main into the LAD, but the fact that we have possibility of carina and plaque sheath mandates to select stent according to LAD diameter and then expand inside the left main. And the length of protrusion inside the left main is not usually throughout the whole length, but just 8 to 10 millimeters, enough to perform proximal optimization. The fact that there is no severe stenosis in the left main guarantees that adequately used pot balloon will ensure good expansion inside the left main as well.
Thank you.
I think Dr. Goran has hit the whole thing right on the top of the nail, and he has almost got everything that we have done in this particular case. So that's a wonderful comment, Dr. Goran. I think here we have used both the modalities of intravascular imaging. So I'm going to show you OCT runs before and after, as well as the IVUS runs before and after. And this is always a dilemma for all of us, whether we should be choosing OCT in a roomy left main like this, which is upfront, looks to me at least 5 millimeters in diameter. So I think we'll find out as to how does the OCT score over IVUS in a situation like this. Sorry, over to you, Dr. Bayolan. You were saying something.
No, I was just telling, even before all this imaging came in 10 years ago, when we saw an osteoproximal lesion, we were always worried. And those were days when elective left main stenting hadn't started. And quite a few of us have burned our fingers, putting an ostial stent and a small dissection extending into the left main. Dr. Bahulan, what do you say about it? I mean, we all tried our best to avoid the left main those days, but now we have been wiser and
as Dr. Goran correctly pointed out, that more than 90% of cases you will have plaque, significant plaque in the distal left main by imaging. So we are right in selecting that strategy of placing stent from left main to LAD as a provisional strategy. And regarding the imaging modality, well, of course, in distal left main, you could use OCT also, which will give you more clarity about the jailing pattern of the side branch ostium, probably better than IVUS. And if you are in the habit of making decision on the jailing pattern of the side branch, OCT will be definitely superior over the IVUS. But I generally use IVUS in the sense that many a time the distal left main will be larger one, and many situations you have to come to the ostium, and in that case the IVUS would be giving more help in deciding the strategy and deciding the procedure details.
Absolutely. And I think if it is an osteoproximal lesion in the LAD, and sometimes it's very difficult to make out whether it is true ostial or osteoproximal, and there is a landing zone of hardly 1 millimeter or so. And if I'm planning to do a pure LED stenting in a situation like osteoproximal lesion, then in that case, I personally prefer IVUS because I can actually park my IVUS catheter into the circumflex and visualize whether I'm positioning the stent properly or not, because IVUS gives me a better far field imaging than the
Yes.
OCT can. And
Yes.
IVUS also gives me a real-time image, which
Yes.
OCT can.
To add on to that point, if the left main is a short, again, IVUS will be helping you definitely better than OCT. Well, sometimes you find that the left main is a short and the bifurcation starts very soon after a few millimeter of left main. And that's the cases also you can verify by the manual pullback and then identify the details by IVUS.
Good point. That's a good.
Sir, Dr. Sridhar and Dr. Praveen has joined us, sir. Shall we hear from them also?
Yeah, sure. Yes, Sridhar, of course. Yes, Sridhar and Praveen, welcome. We would value your opinion on this particular case.
Very good evening, Dr. Bahulayan sir, Dr. Anil and Dr. Suhas and Dr. Deepak for conducting such a wonderful show, and Dr. Goran Stankovic. This case, where I see it is looking like a lipid-rich block. I don't see much calcium in the proximal LED. But angle is very favorable, unlikely to close, because even if you take the imaging, the predict of the bifurcation, the side branch closure is less likely, 90 degrees angle, and ostium of the LCX appears to be a disease-free. And though angiographically not much plaque in the distal left main, but is always preferable to extend from LM to LED. Why? Because sometimes 25% of the stents can go longitudinal stent deformation, which was noted in imaging studies. Either it may shorten, you may miss the ostium, or it may elongate, and that may encroach onto the L6 ostium, which may create some turbulence. So if you go with the left main to LED stenting, the bifurcation is very well controlled. But the part also when you do imaging should be done, because if you are extending to the ostium, that's different. But if you are landing in the middle of the left main, if you don't do imaging, if you inappropriately size the balloon, bigger size balloon, it may dissect the proximal LMC and you may have to put the one more stent. So sandwich technique, you have to use it. So in such circumstances, do the part and assess the side branch. If side branch the stud free, then no need to put another balloon and like a minimal kissing, no need to do. Suppose the side branch is stud free, then absolutely do the part and do the LED. Assume that we have not done LED, LMCA imaging. If there's some lipid-rich plaque is there in the distal left main, most likely patient is going to develop the proximal edge restenosis rate, because studies have shown if the more than 50% lipid-rich plaque, the ISR rate is very high, because this is a very crucial segment. Left main bifurcation, it closes the LED as well as it will enter into the L6. In such circumstances, preferable, the left main to LED is more controllable. Even tomorrow, suppose if the patient is having some stuck problem, you can cross it and extend one more stent like a T-tap. That is also a very good option. But my opinion, left main to LED, that's the best option. Do the optimal part and do the optimal post-dilatation of the LED, and with image guidance is the best way. Thank you.
I'll play the video a little more.
Or we will land up with positioning the proximal end of the stent on a plaquey area in the distal part of the left main. And would it be better to actually do a provisional stenting across a very roomy circumflex origin and probably have a very safe night for the patient as well as for ourselves? Next shot, please. There is an interesting thing here which I wanted to point out, was that the circumflex in this view is not coming out exactly from where you would like it to, and therefore the positioning of the stent right at the ostium of LED can sometimes be difficult in this particular view. But of course, as I showed you before, the epicaudal view and the areocaudal view are good enough in case we decide to position the stent in the LED ostium. Of course, that decision is going to depend upon what we find on intravascular imaging. Next shot, please. This particular angle also clearly depicts that there is a scooped plaque at the origin of the LED, which is probably going towards the left main. So my upfront impression is that there is moderately severe disease in the proximal most part of the LED, extending up to the first major septal, but the proximal part of the lesion is extending into the left main to some extent. We will now use a routine regular wire that we are comfortable with to cross the lesion. And we can get a OCT catheter ready by that time. Can we have the OCT catheter, please?
I'm going to put it on pause once again in case you want to discuss here the type of stents that we would use in a situation like this, where the LED upfront looked to me around 3.5 to 3.7 in that range, and the left main looked in the range of approximately 5 millimeters. So any comments about the stent expansion limits of various types of stents and the type of stent that one would use in a situation like this? Hereafter, the video is on mute, so I'll keep playing and pause it only when you ask me to, or I feel it is relevant to pause. So your comments, please. Thank you.
Dr. Anil, any comments on that type of stents? Well, of course, the stent, as you said, the expansibility, as Dr. Gorang has pointed out, that the stent size is based on the distal reference. That's the LED, which you presume that it is 3.5. And your sizing of the visual sizing of the left main is 5. So you should have a stent which has got the expansibility. A 3.5 millimeter stent should have the expansibility of at least 5. So I think select a stent which that expansive capacity. Then the geometry of the stent, is it important? The side branch accessibility, is it open cell design is preferred in this case, or any of these stents will be used? What is your opinion on that? Deepak, am I audible?
Sir, Dr.
Yes,
Anil,
you are audible.
muted.
Yes.
Dr. Anil, you are muted.
Right now, we know that the open cell variant stents are expansible, and now we can go up to 3.5 can go up to 5.5. We even have the 4 millimeter stents available. But for this, the LED diameter being 3.5, I think we should take a 3.5 stent and go up to 5.5 for the proximal optimization of the left main. So after the OCT, the sizes would be more evident, and then you can plan the size of the stents.
Absolutely. Absolutely.
Any comments, Dr. Praveen, or you are online?
Yes, sir. So first of all, thank you, organizers, especially Dr. Deepak, for inviting me here. So as I was hearing the discussion, reference diameter, which is around 3.5 here, and we could use any of the newer generation stents, which could be expanded to up to 5 or even higher. The 3.5 can easily go up to 5 or 5.5.
Dr. Suhas, you want to continue? And audio, suddenly
yes, basically,
muted. Yeah.
No, I have muted my video completely. So it is now here onwards, it is completely on mute. But we can discuss in case you want to talk about how to prepare an OCT catheter, what are the precautions to be taken. I think it's a worthwhile point to be spoken about at this juncture. Do not kink this. Make sure that you flush it with a smaller syringe. Make sure that you do not flush with a lot of force. And probably when you are clicking the device, it is to be turned in the clockwise direction. When you plug it to the pullback device. So I think one can discuss here how to prepare a catheter in case you would want. Otherwise, I'll go ahead.
Yeah, I think you go ahead, please. Yeah.
Okay, okay. So you can see that the catheter is now ready to be inserted, and before inserting it, we make sure that we get a nice fisheye view. Calibration is done. Make sure that the wire is placed distally very well. The catheter has to be very coaxial because it is a bulky catheter. If it is a tortuous artery, it can give you problems. The catheter can back out. That's the first marker which is coming, which is the tip of the distalmost tip of the catheter. Then there is that second marker that you see. That is the imaging apparatus, and that has to be in the normal segment distally. We will now start the imaging. Any comments so far? Anything?
What mode we are using it? Is it going to survey mode for the first pullback?
Sorry, what was that? I missed it out.
No, which mode you are going to utilize for pullback the catheter? Is it the survey mode?
Yes, yes, it is.
No, I think that is one thing which is to be commended. Even for post-stenting also, many people are using survey mode because you can use a lesser dye, and then the clarity of the stent details also will be good even survey mode.
Absolutely, absolutely, I agree with you. And here you must be wondering as to why am I taking the second wire? Any guesses as to why I'm taking the second wire? Any expert comments on this, please?
But sometimes some people, they use it for buddy wire technique, like to push the catheter. But the anatomy appears to be, you can track it very easily. We use more when they touch us, like if you are entering into the L6 or if there is calcium, fibrocalcific lesion, that time wire we keep. The most of the time, instead of that wire, what we use, you pull back the OCT catheter, hold the both wire and that acts like a buddy. Then you advance together. Many times it will be very successful. And otherwise still, you can put the guide liner, through the guide liner you pass and selectively enter into the LED. So that this happens particularly in a very large left main, very large L6 is there. When you are giving a contrast will be, if the LED's angle is there, contrast will more go into the L6. So we will not get the sufficient image. In such circumstance, put the guide liner, enter into the LED ostium or just at the ostium, then inject, you can get the better LED images. Otherwise, the artifacts will be much more. So this is a tip what we use.
That's a good point. Dr. Kasuri, one point on injecting the dye through the guide liner or a guide extension catheter. Have you had any problems any time with that?
Usually when you use the guide liner, someone should hold the guide liner. If you don't hold the guide liner, you allow the catheter to move freely, because if the catheter you are holding, then naturally anywhere friction is there, like if that calcified, you get seesaw artifacts, and you will not get, a lot of reverberations will be there. So, but if you are not holding the guide liner properly, sometimes if you give a forcible injection, it will go deep in, it can dissect. So that's the reason, always hold the guide liner.
Yes, yes. One time I hear that Ziad Ali mentioned that in their experience, they had ventricular tachycardia and ventricular fibrillation in right coronary artery when they injected very forcefully. So I think one has to be careful. It is useful to have a selective injections, but injecting through the guide liner with be cautious.
Just a couple of points to be remembered, to be kept in mind before introducing the catheter into the guide catheter. Many times we forget to activate the catheter because it's a hydrophilic coated catheter. You need to wipe it with saline so that it gets activated, so that it moves easily through the guide catheter. That's point number one. And point number two is always make sure that the catheter is well perched, because you go inside the coronary artery and you make sure that it's not well perched. And if you try to purge it inside the coronary artery, there is always a small chance of air embolism into the coronary artery. So it's always, one should make sure that it's well perched before it's introduced into the guide catheter.
Very soon, I think on your screen, you should be able to see the OCT images. And if you want to make comments about the OCT images, please.
Yeah, right now we are not seeing the OCT image.
Okay, there you go. That's the OCD run.
Yeah,
I'll
that's
play
right.
that once
Yeah,
again.
yeah, yeah.
I'll play that once again, I think. I've reversed that just by 10 seconds. So you'll see that in the next 3 seconds. Yeah, that's the pullback.
It's not moving.
Yeah, we can see this. Yeah.
Okay.
Right.
So that's a bifurcational view that we have gone on. And you can see there that there's a large opening of the circumflex. That wire is going into the circumflex. And I put that to basically mark the origin of circumflex, which seems fairly good and nice, but we haven't done the cross-sectional analysis yet. But it's a very roomy origin of the circumflex. And such a case, as somebody said, is very appropriately considered for provisional sideband stenting. Now we will do the analysis in various views. You can see that the tightest points have been marked by the yellow line that you see. That's the origin of the circumflex, which is being shown here. And that's the origin of LAD, which shows a significant fibrous plaque extending from 6 o'clock until 3 o'clock. This is on a lower resolution, a bigger, lesser magnification. And this is a tighter part of the lesion, which shows that it is predominantly fibrous area all around. As we go distally, the lesion becomes more and more critical, and the luminal area there is just barely 2 millimeter squares, and the diameter is 1.61. Then there is a normal segment, a kind of normal segment. It does show a significant lipid core in the distance at 6 o'clock, a fibrous plaque. We have come back again into the left main. That is the left main. Left main measures approximately, we will do the diameter measurements here. That's a good part to take the EL to EL measurements. It measures approximately 5.14, and in a couple of other diameters, we got it as 5.18 to 5.2. So that's the left main diameter. Here you can see that there is a significant fibrous plaque in the origin of the LAD, extending on the superior aspect of the distalmost part of the left main. So obviously, all of you that you said is absolutely correct, that the plaque is extending into the left main, and we are justified in doing a provisional stenting here. Anybody wants to make a comment?
So I think in terms of the plaque morphology, it is reasonably a straightforward case, mostly fibrous plaque, not much of a calcium and not much of a very lipid-rich plaque anywhere. What was the if you go by the MLD match criteria, what is the distal reference point which you are selecting? And
we'll come to that. We'll come to that
please,
in a second.
please.
Yeah. That's the left main, which is about 5.2 at the most. And we will now go to the distal reference point. And to our surprise, the distal reference point beyond the tightest part measured actually more than 4 millimeters, which was quite a surprise.
We are not seeing in the screen that one, the distal reference.
Yeah, we'll show it to you in a second. That is the mid part, which
That's okay. Yeah,
is normal. And then that is the tightest part.
Yeah.
Once again. And that's the distal reference. That's the distal reference normal. There is a side branch. You bring it to the normal part. Do you agree that this is relatively
I think
normal part?
yes,
There's minimal
normal where you have probably the largest lumen.
Correct. Absolutely. So there we put a marker there. And I wanted to put a stent approximately 10 millimeters proximal from the bifurcation.
Yeah.
So what is the present consensus at this point of time regarding stenting from the LED into the left main? Is it enough that you have the stent protruding almost 10 millimeter or 12 millimeter way back into the left main? Or here it appears as if the left main is around 15 to 18 millimeters. So should we really cover the entire left main right from the ostium of the left main into LED? Or is it enough that we have at least 10 to 12 millimeters so that we can do a proper part in the left main?
That's
Dr.
a very
Goran
good
and
question.
team.
Yeah.
Yes. Absolutely.
Yeah, we often keep discussing this, and it seems to be a bit of operator dependent rather than guidelines. Do we have any guidelines for that?
Can I make a comment, please?
Go ahead.
Yeah, I feel that we always have to think about re-intervention in case there is a need. In a situation like this, if you had a stent thrombosis, it would be a disastrous situation that if the stent is hanging in the ostium of the left main or hanging out of the ostium of the left main, engaging a catheter in an emergency where you have a couple of minutes to engage and probably cross the lesion or cross the thrombus, it is best to not cover the ostium for sure. And as you rightly pointed out, I think covering about 10 millimeters would be good enough, because that will give you some space to do a good pot and make sure that you have a great approximation of the stent in the left main. So I would be inclined to think about the re-intervention, whether it is acute or a plan at a later date.
Dr. Goran.
Yeah, thank you very much. I agree completely with comments, but in this specific case, we have image evidence that there is no significant plaque. This left main is healthy. So we really don't need, it's expert consensus, we really don't need to extend the stent throughout the length of a relatively healthy left main. The only diseased part is actually part of the plaque which protrudes from the ostium of the LAD. So for that reason, and for the easiness of the index procedure as well, because in this case, you will jail the wire in the circ, and having jailed wire in the circ, if you extend the stent up to the ostium, you may longitudinally deform with the guiding catheter the stent at the level of the ostium. And if it protrudes inside the aorta, again, the likelihood with jail wire to create stent deformation is very high. If we don't cover 5 or 6 millimeters, as you calculated here, you decrease the risk of longitudinal stent deformation. So this is additional consideration why not to routinely extend. However, if there is diffuse disease of the left main, I would encourage stenting the whole disease segment, taking the risk of stent deformation.
Okay, so some individualization has to be done for every case, I presume. Take the factors along as we do the case.
So let's say you have a 8 millimeter long left main and it's diffusely diseased, and you're committed that you're going till the ostium of the left main.
Absolutely.
In that situation, when you go through the femoral approach, it's always easy to manipulate the guide catheter. But when you are going through the radial approach, getting the stent right at the ostium or protruding 1 millimeter into the left main, it's always challenging, disengaging the guide catheter. So are there any specific tips to manage this so that the guide catheter doesn't move away from the ostium and it doesn't get disengaged? What are the tips just to manage the guide catheter in these particular situations when you're planning for a radial procedure?
Yeah, if I may answer first what I do myself, this is so-called left hand maneuver. So with the left hand, you are actually controlling the position of the guide catheter, which is most of the time outside of the ostium of the left main, if it's stented up to the ostium. And then with any device getting inside or outside. First, if it's balloon, you wait complete deflation of the balloon before pulling balloon out. IVUS catheter, whatever device you are inserting or removing, you need to do it carefully, disengaging the guiding catheter throughout all those maneuvers. Only when you need to insert device like a balloon, then you position your guiding catheter inside the left main in order to make sure that you smoothly coaxially enter inside. Otherwise, if it's outside, even engaging with balloon can create stent deformation. So jailed wire increases the risk of deep throating and deformation of the stent. So as long as you have jailed wire, you keep position of the device of the guiding catheter outside of the left main.
Dr. Deepak, sometimes I find having another hand, an assistant or a second operator holding on to the guide, and when the other manipulation is happening, that also helps. Any thoughts on that?
So many times when you have the 7 French guide catheter through the radial approach, by the time you get the stent in, there is some amount of radial spasm. Manipulating the guide catheter always is challenging with the 7 French through the radial approach, and there is always a small possibility that it can just jump out of the left main ostium. So it has happened to me. So what I try to do nowadays is try to get the wire and the LED into a septal branch, a harmless septal branch. And rather than pulling out the guide catheter, I try to push the wire deep into the septal branch so that the guide disengages, so that it can be aptly positioned right at the ostium of the left main. Any thoughts on that?
I'm afraid of pushing with wire because wire exit can create more problems than disengaging the guiding catheter. But everybody has different experience, and if you have bad experiences in the past, and I have one, I really try not to push the wire to disengage.
Yeah, that is.
Dr. Deepak.
Yeah, Praveen.
Hello. Yeah. So what I do for positioning the stent is just as the stent reaches the tip of the guiding catheter, I open the Tuhi and then push the stent so that the guide backs out. So while you push the stent, you just keep the Tuhi valve open so that you can have the guiding catheter backing out, and you can just position the stent accurately that time. Also, like you said, if you have a tip of the wire looped in the distal LED, you can push it also. But I haven't tried the septal technique which you have told recently. But the other two techniques helped me many a times.
Dr. Vijay too has joined us. Vijay, please.
Yeah, you don't use a septal wire, so at least it gives some control, so you don't have to withdraw a guiding too much when you position your stent. Another thing is whenever we do little complex case through radial, we use the support wires rather than, particularly if it wants to find too much of guide catheter manipulations. Now we have many support wires. We routinely use the cyan blue extra support wires that give reasonably better support. So guide catheter manipulations doesn't result in gross disengagement of the guiding. And always keeping two wires still helps, even you just pull it back. But if you're stented in front, but till you position your stent and deploy your stent, keeping two wires also helps. So guide catheter doesn't back out too much.
Okay, so do you want me to play the video? Here are the runs of the IVUS.
And why did you do two imaging this way?
Yeah, because I just wanted to bring it up. I mean, it was not really necessary. I agree, but I just wanted to bring out the differences between IVUS and OCT. And I thought that could become an interesting discussion here, because the left main is roomy. Somebody might think that OCT may not be most appropriate, something which is measuring 5 millimeter plus. I have paused here because I can see.
You're able to see even.
Sometimes I feel that I see much more with IVUS than what I can see with OCT. But of course, OCT gives wonderful pictures. Here you can see that around 9 o'clock position, there is a thrombus seen here, that intraluminal deficiency that you see here now on the screen. But most of the findings that were seen on OCT are almost being kind of confirmed here. Any comments about the?
No, I think one
But
point,
OCT,
having done the
OCT did not show any thrombus. I think it did show any
I
thrombus.
don't see any thrombus. It's
And OCT is more sensitive to detect the thrombus than
thrombus. Absolutely.
area of fibrosis.
Hi, Vijay.
Sir.
One thing, you asked about two imaging here, that IVUS and OCT. I would be interested in Dr. Suhas to show what is the plaque in the distal left main, because IVUS should show the plaque more in detail than the OCT.
Yes.
Can you show any difference you have found?
Yes, we have
OCT apparently looked that there was not much in the left main.
We will show you that area exactly, and we have put a cursor there. We have indexed that area.
Yeah.
Because I think that is of interest to all of us as to what does the distalmost part of the left main show.
Right.
So I think we will have to be patient only for a minute or so, and we will get you all those references.
Right.
A small tip here, you have to keep your field of view depth maximum when you do left main IVUS, particularly when you have a big left mains like this. Because in IVUS, once you keep a depth at some level, you cannot adjust it post, as you do in OCT, where you adjust the field of view.
Yes. Here you can see that these are the various reference points that we had chosen. And the distal reference point, the EM to EM measures almost 4.6 to 4.5 millimeters in diameter. And if you gave a leeway for the intima, then it measures almost 4.2 millimeters. If you looked at the measurements at the distal end of the left main, you can see that the plaque burden is close to 40%.
That's right.
So which is quite significant.
That's right. That's very important.
So I will go on to the next one.
Which you have used for selecting the stent. You said the distal reference point was around 4?
4.2, yeah.
4.2. So what stent do you have to are planning to choose?
Now that's exactly what I want you to discuss and tell me what.
Because we were developing our discussion on 3.5, which will go to 5 in the left main. Now you find that the distal reference point is 4 by both OCT and IVUS.
Absolutely. Absolutely.
Yes. So are you going to use a 4 millimeter stent which will easily comfortably go into 5?
Now you will be surprised when I actually looked up the literature of Abbott vascular. I was surprised to see that they're
both same. 3, 5, and 4 are same.
Yeah, absolutely. I mean 3.5
and even Medtronic Onyx is both are same.
Yes.
Only Boston stents differ, sir.
Absolutely. Medtronic probably also on paper, they say that it goes up to 5 millimeters and beyond. There are certain papers which have said that the Medtronic stent Onyx can be stretched up to 5.9 millimeters. But wherever I looked up for the Abbott vascular stent Zans, it said that it goes up to 4.5 and not beyond. So my concern was whether we should be using Zans here or not. But of course, in my experience in the past, I have stretched it very comfortably up to 5 millimeters. So we decided finally to go for a Zan stent. Any comments, please?
Sir, when you look at the signs as well as Onyx, whatever be the stent, even if it's 3.5 or 4, the signs it would go up to 4.5. And the Medtronic, the Onyx, it would go up to 4.75. Only 0.25 millimeter difference is there. But when you go with a 4.5 Onyx, probably you can go up to 5.5. But this vessel, when you look at the IVUS, I felt that the ostium of the LAD, there is some amount of negative remodeling. It is looking almost 3.75 or so. So in a 3.75 vessel, going with a 4.5 millimeter Onyx may not be a good option. So probably we have to resort to anything that is around 4 millimeter. So 4 millimeter of signs and Onyx, no much of difference regarding the final diameter. It's 4.5 and 4.75. So probably it's your call.
But most of us have gone for 3.5, even up to 5, 5.5. So Vijay Kumar, do you think that there's a shortening that happens, or You should
But
not be
so there's
modeling.
always difference what the papers say, that papers, the bench models say a different size. And if you see, we have went through all the company recommended ones, but currently none of the 3.5 goes up to 5, at least as a company recommendation. So where
That is
there's
perhaps a safe way to go by that. Most of the questions
and
of
only thing is
3.5
particularly when you use 2 connector stents, if you expand up to 5, you do a stent boost, you got terrified, particularly when you have left main disease.
Yes.
And recently we had a patient where we had to stretch open to 4.5, one of the 2 connector stents, and we had a tremendous amount of tissue prolapse. In the end, we ended up with lumen flow area of 6.5 or 7 in the left main. So that risk is also there, particularly when you have left main. If you don't have much of disease, then it doesn't matter whether you stretch open or you just deploy to normal pressure. Maybe others might have different opinions. So what, Deepak, sir, what you do?
We
I
always
can add also from my practice, makes a lot of difference if there is plaque inside the left main or if there is no plaque, like in this case, because plaque fills in the gap between the partially under expanded stent and the vessel wall. In this case, we really need to take care of the selection of the stent and make sure that it's stent with the expansion capacity up to 5.
Any comments?
Goran, what is your choice of stent here? Maybe you would have used a different stent, or
regularly we use Resolute Onyx after EBC main study. For us, Resolute Onyx really gives you broad range, good expansion capacity, good visibility. So this is what we use in case of need for over expansion inside the left main. But I think that also Science Expedition, if you have Expedition, can go with 4.0 up to 5.6.
Yes, exactly the comment from an audience, Dr. Benijos, that the Resolute Onyx can go from 3.5 and 4 can go up to 5, and 4.5 and 5 can go up to 6.
All right. Any comments about the pre-dilatation of this lesion? Because given that we have a lot of fibrotic tissue here, would you consider?
And in OCT, one more comment, it is rather than fibrotic tissue, it is all layered plot. So that shows that in between areas you had, that shows it is a multiple ACS events rather than a single event. So you can see carefully there are, even you have maybe might have had a previous plaque rupture, and you can see lipid-rich plaque inside and 2 layers of your endothelium covering that. So it is more of a layered plaque rather than a fibrous plaque here. Any comments from others?
Yeah, Vijay, you always see more than what others see.
Yes. Vijay, do you think that this layered plaque can be considered as a pre-existing or recently
that is what
active coronary syndrome?
That is what literature says.
Yes,
not
yes,
sure
that's
the
what
IKH
exactly.
studies. And
Yes,
another thing, for such a big vessel to develop this type of stenosis, you think is one event is enough? I think it should be multiple events, right? Even logically, you think also. And another thing, maybe when we do this type lesions, better to always dilate and give some NTG before we take measurements. Even OCT, unless you're really interested in plaque morphology, you don't want to disturb anything, it's always a better practice to just dilate with at least a 2.5 balloon before you take your images, and give good amount of NTG, and vessel grows. This vessel may not be, but particularly when you have RCAs, it is always a better practice to give some good dilatation, give good NTG, then you take your images.
Jigma, this distal reference was 4. We didn't answer the question whether we will take a 4 stent
I
or
think 4 stent will be the appropriate choice. What others think? What Dr. Goran think about it? Deepak sir and Pagalian sir, what do you think? You would have selected only
I
4
also
millimeter.
thought, initially angiographically, I thought of 3.5, but having seen the imaging and clearly showing by Suhas that both IVUS and OCT showing 4 above, 4 stent could be nicely placed and it could be made it into 5 for left knee.
Absolutely. And we have chosen to use a scoring balloon here, actually an angiosculpt of 3.5 millimeter, because we thought it is better to dilate this with a scoring balloon. So 3.5, 15, going up to 14 or 16 atmospheres. The images that you see in front of you. And you can clearly see there is a impression on the proximal part of that angiosculpt when we dilate.
Is there any special reason why you have chosen an angiosculpt instead of a
Because
balloon?
because there were a lot of fibrotic areas intervening those lesions, and you can see that there's an impression. We had to go up to 14-16 atmospheres, which is not regularly recommended for an angiosculpt to go as high as that to get rid of that waste. So we thought probably if we give cuts in the fibrotic area, we might yield a better lumen. So that's why we used a scoring balloon here, 3.5 millimeter by 15, in the distal part of the lesion as well as in the proximal part. I'll quickly run over this because we are running out of time. This is the proximal dilatation with the same angiosculpt.
What size angiosculpt was that? Was it 2.
That was 3.5.
3.5.
So now I think we were more comfortable using the 3.5 because we thought, saw that the entire LAD that we were dealing with had a diameter more than 4 millimeters. So this is a 4 by 38 millimeter sized Zan's expedition.
When you say angiogram, it doesn't appear to be 4 millimeter, maybe 3.5.
Yeah, that's right.
You are deploying at nominal pressure.
We deployed it at little over nominal pressures because in a long lesion, I prefer to do it slightly above the nominal pressures and do it for a period longer than 15 seconds to make sure that the entire pressure is transferred. I'll keep playing and keep telling you exactly what we have done after this.
Yeah.
After this, we have gone for pot.
The size of the pot balloon is the 5. And what is the type of the balloon which you have selected?
We have gone for a non-compliant 5 millimeter. But as you all will agree that when you go at a very high pressure, even with a non-compliant balloon, they become compliant beyond 18 or 20 atmospheres. So this is a short 5 millimeter balloon. And this was done predominantly
Now, the placement of the pot balloon is very important. What is your recommendation and how are you doing it here? Will you tell us?
Basically, pot should not be done at or beyond bifurcation. If you are using SKS, then pot should be done at least a millimeter proximal to the bifurcation. But if you are doing a provisional stent, probably with a roomy circumflex like that, you can safely do pot with the distal tip of the balloon extending just into the left anterior descending artery, which we have done here.
Sorry, sir.
I think the marker of the balloon really helps us for the placement of the pot. The marker should be just in front of the carina, and you have to have a view ideally suiting to show the bifurcation clearly and the carina very well made out. In that view, you should utilize for placing the balloon. And the distal marker should, if it coincides with the shoulder, that sort of a balloon will clearly give the good effect of the pot. I would like to have Goran's.
Yeah, I have a really important question. Why you remove jail wire when you do pot?
I think there was, according to me, I felt no need of keeping that wire for a longer time especially when I was doing a very high pressure inflation in the left main. Of course, we all know that these wires can be pulled out very comfortably after having had a very optimal pot. But why have it when you don't need it? So that's why I think I pulled it out, having made sure that the circumflex was flowing extremely well.
Yeah, I think I have to defend. There are several advantages of having jailed wire, especially in case of carina or plug shift and compromise of the circumflex. This jailed wire is not only a marker, but it's also possibility to go with small balloon on the jailed wire behind the stand, and in case of closure of the circ, in case of occlusion, you can go with balloon on a jail wire and reopen the circ. And there is really no single disadvantage with modern generation guide wires. We don't routinely have problem of removing jailed wire after pot. So it's the position of the European Bifurcation Club, and I think it's important message for our audience that we should not remove jail wire before we complete pot.
Dr. Goran, do you have any preference for the balloon for when you do pot? And do you have any experience with newer pot balloons?
I don't know which newer pot balloons you have on your mind.
There is a dedicated pot balloon. It has come out now. Maybe
Chinese
I can
one? One from China or?
Yeah, I think so. And if it's currently available balloons, so what is your preference? You have any preference?
Usually, if it's like in this case, stent ends within the left main stem, so it's not up to the ostium. I use non-compliant balloons, adequately sized, and I really don't go to very high pressure. I think position of the balloon and size of the balloon are two key components. If you have a jailed wire, when you implant the stent, jailed wire is pushed a little bit laterally. So carina position is distal to wire separation. And this is important message for positioning of the distal marker, because if you go with distal marker 2 or 3 millimeters proximally, then you will not open cells in front of the carina. And the key aspect of pot is actually to open cells in front of the carina. And this will help you distal rewiring and actually covering and scaffolding the ostium of the circ after balloon inflation. So I believe a non-compliant 5.0 like it was used now is exactly the same as I would recommend.
So that balloon is a pot PTCA balloon from China, as you said. It is a Bros Medical.
Yeah, but I don't have personal experience. I know they are planning study, but I don't really know more details.
Thank you.
That's the post dilatation of the LAD area stent with a 4 millimeter non-compliant balloon up to approximately 18 to 20 atmospheres. And we often do this under stent boost guidance.
Deepak sir, time please.
So there's a comment in the chat box by Dr. Benny Jose. Apart from the apparent benefit of the jailed wire in protecting the side branch, keeping it jailed also significantly improves the guide stability, especially during left main stenting close to the ostium. a very valid point.
Absolutely.
Dr. Suhas, can we rush through a bit more
Yeah.
faster?
Certainly, we can. I thought, meanwhile, you wanted to discuss anything about various methods like stent boost that can be used here. So that's what we've got here so far. We'll quickly take you through the OCT runs. From my side, the video is going to last approximately 5 minutes and 30 seconds. So I will probably rush you through that. The imaging did show that the stent in the LAD was not very appropriately approximated. On IVUS, in the OCT, we didn't have that opposition rendering very good because of the snag in the software. But based on the IVUS findings that there was no good approximation with 4 millimeter dilatation of the LAD, we went on to dilate the distal LAD with a 4.5 millimeter balloon up to approximately 16 to 18 atmospheres. Here you can see that on cross section, the stent is very well opposed, but the longitudinal rendering was not possible due to the software problem.
We saw a little bit of plaque protrusion into the stented segment. Vijay, at what point of time, beyond what percentage of plaque protrusion would you again go with a balloon and do a soft dilatation of the stented segment when you find plaque protrusion?
I don't think there is any specific recommendation. The elementary, we had 10% of the lumen occupied by a plaque.
Yes. Here,
I don't
was
think
showed,
any specific recommendation.
If you focus here on this image, you can clearly see that this stent needed more opposition in this particular area, which was the distal part of the LAD. Here too, but left main stent looked good. So this is the post dilatation of the LAD segment of the stent with the 4.5 millimeter balloon.
And only when I feel that residual lumen area or flow area is inadequate, suppose you take an LAD, if the lumen area is already less than 4 or 4.5, that is when we try to intervene, just to do a prolonged balloon dilatation. If it doesn't work, we put an additional stent.
So that's the final picture where we have post-dilated the LAD segment of the stent with a 4.5 millimeter balloon. And the pot was done with a 5 millimeter balloon up to 18 atmospheres, making it approximately 5.25. And that's the final picture showing the stent in the AP cranial view. A very acceptable distal result as well. So with that, I just wanted to thank Dr. Deepak, Dr. Bahulen, Dr. Anil Kumar, Dr. Goran. Thank you very much for your lovely comments and the involvement. Thank you.
Bahulen sir, you're muted. Bahulen sir, you're muted.
I think you require really deserve congratulations for demonstrating the provisional stenting very nicely, and then showing the utility of imaging to select the stent sizing, approximating it very nicely with the good deposition and expansion. Any comments from anybody else for this case, or shall we move to the
I differ. I do differently,
yes,
because particularly when you do the left main, there is a one study. This was reported by OVIDA, and they have conducted a series of patients where they did LM mid and versus ostium. Ostium is no need to project into the aorta, just at the ostium, but the restenosis rate is less when they have extended to the left main ostium compared to the mid LMCA. The mid LMCA, sometimes what happens, we have seen some patients when we did the pot, that there is a precise sizing with the imaging is very, very essential. If they oversize the proximal dissection, sometimes it may not be seen on angiogram. And when it is not seen, even gross malabsorption not seen. So in such cases, if you leave, patient may come with the angina or ISR rate. So another thing is regarding stent, still, though the initial imaging study showed it's about 4 diameter, it's okay. But otherwise, even 3.5 also comfortably, you can extend up to 5.3, 5.5 many times, nothing will happen. And even EBC, even that study, even book also showed even Science Expedition 3.5 can go up to 5.3. So that chart is also there. And any new stent, any new generation stent, comfortably you can do the because the cell size is reasonably good, more than 3.5 majority. So only biometric stent, they said it's 4, but the majority of the stent 3.2 to 3.5 open cell that easy to cross the side branch. And sometimes they say these there's a quadrant studs versus the circular studs where it can sleep. Different companies they say different things, but in my experience you can comfortably cross with any new generation stents. I think wonderfully done, very nice case.
We'll insert the next presentation.
I think
Keynote lecture.
we'll move on to the next one. We'll invite Dr. Goran to give his talk on the tips and tricks of provisional stenting.
Can you see my slides?
Yeah, very well.
Okay. First of all, I would like to thank Dr. Davidson for kind invitation to participate. I really like to discuss especially the topic of provisional. My only conflict of interest is that I'm a member of the European Bifurcation Club, and it's a group of people with great interest and passion about bifurcation treatment. This is the first meeting of EBC in Bordeaux in 2005, and this is the last meeting we had last year as a hybrid event in Brussels. So what I'm going to discuss is mainly summary of the most recent consensus from the EBC, and that consensus is based on the discussions during the last meeting in Brussels. So as a background, since the beginning of bifurcation PCI, there are several studies evaluating and comparing treatment of provisional versus systematic two-stent strategy in various kind of non-left main and left main lesions, but all of those trials show a lack of benefit associated with systematic coverage of both branches. And even European Bifurcation Club 2 study, which compared in non-left main large true bifurcation lesions provisional versus culotte stenting, which is sort of, according to European philosophy, first choice for two-stent strategy up front, did not show benefit of culotte compared to provisional. And if we follow the patients for longer period of time, like it was done with individual patients from the first study, Nordic, and then BBC1, we see that at longer term follow-up, after 2 or 3 years, there is divergence of curves over mortality.
Recording in progress.
And systematic two-stent strategy at 5 years of follow-up showed significantly higher mortality, all-cause mortality with more metal compared to single stent. So we were looking for new generation stents, updated technique, and Professor Patrick Seruyus presented at EBC 2021 10-year mortality in the syntaxis and the impact of the stenting technique, and this is similar curve, all-cause death at 10 years, in red 1 stent, in blue 2 stent technique, and you see that similar pattern is seen also in the syntax trial. After 5 years, you see divergence of curves, and this reached statistically significant mortality difference at 10 years. So these are the reasons that EBC keeps the same ethos for the treatment of all bifurcations. Try to keep it simple and safe, try to limit the number of stents that you use, but the key that was nicely demonstrated in the previous session, respect the original bifurcation anatomy and try to reproduce it, expanding tubular stent according to different diameters in the proximal and the distal part. So we aim for well-opposed and well-expanded stent with limited overlap. So for us, provisional side branch stenting strategy is the standard approach for treatment of the vast majority of bifurcations, including the left main. And this is the MEDS classification that European Bifurcation Club uses for classifying stenting techniques. So there are 4 classes. First one is main proximal first, so it's actually stenting only of the proximal part of the main vessel. And D is V-stenting at SKS with long metallic neocarina, which are really rare techniques. And according to European Bifurcation Club, we don't suggest to use SKS because of the high rate of stent thrombosis and TLR and difficulty in treating restenosis. So for us, there are mainly 2 different types of stenting techniques. A, which is provisional, which is actually stenting from the main vessel, either into the distal part of the main vessel, or inverted provisional, stenting from the main branch into the side branch, like stenting from the left main into the circ. And then the other technique is side branch stenting first. So this is currently double kissing crush. So we either have techniques starting by stenting from the proximal main vessel or techniques starting with the side branch. All these A techniques, either A or inverted A, are considered provisional and give possibility for flexibility. You start a sequence of steps, and these are the steps we saw in the previous case, main vessel stenting and then pot. But if necessary, we can do also side branch opening, and we can also perform kissing balloon inflation, and we usually stop after each of these steps and we evaluate the result. When we achieve good result without compromise of the side branch, we can stop this procedure at any point. However, if there is a diffuse disease or if there is a compromise of the side branch, we can finish provisional, putting the second stent either as a T or TAP or culotte. So there are variety of open options when you start by stenting from the main vessel proximally. If you start by stenting only ostium of the side branch, then from the beginning you determine that you will use 2 stents. And don't misunderstand my point. I'm not saying that 2 stents are bad. I just say that if you start provisional, you can always end up with 2 stents. But if you start DK crush, you actually have to finish procedure with 2 stents. So this is my point. Provisional is done as a sequence of layered stepwise strategies. We wire both branches, we predilate main branch, but of course, if there is diffuse disease of the side branch, it's left to operator decision whether or not to predilate the side branch as well. Stent selection, it was excellent demonstration in the recorded case stent should be sized according to distal reference, and then pot, mandatory step, and I think the point which made a difference in the evolution of bifurcation PCI. Because up to this point, we actually recommend provisional strategy up to pot as a routine and mandatory steps. After pot, we can do optional kissing for large side branch, pot, kiss, pot, or if we need second stent, in that case, kissing becomes mandatory. Just demonstration for our attendees of 3 different diameters, so coronary vessels don't taper linearly. At each bifurcation point, we actually have step down in diameter of the main vessel. And it's important to understand this step down because having stent selected according to distal main vessel results in severely grossly underexpanded stent for proximal diameter. And this is why pot is mandatory to fix this one. So these are visible heart lab images showing jailed wire and stenting of the main vessel with diameter according to main vessel. And we need to know the expansion capacity, and there was very good discussion that I would like to point you to Foyn article in International Journal of Cardiology 2016, because here he measured in the bench testing maximum expansion capacity of different platforms for currently used drug-eluting stents. So when we discussed the Resolute Onyx, there are 3.5, 4.0, 9.5 crown platforms, which could be expanded to 5.5, and there is extra large vessel with 10.5 crowns with maximum expansion of almost 6 millimeters. There is also Megatron now, which can go up to 6. So these are 2 platforms currently available that you can use for extremely large left mains. Why pot is important? You see after stenting that your wire, if you try to go into the circ, can really go outside of the stent or can go in and out unless you finish procedure with pot. And also on the OCT pullback, you see gross under expansion proximally. Here is cartoon which I made with my fellow Dr. Zlatko Mehmetbegovic to show you how to do pot. So your distal marker should be in front of the carina, so not crossing the carina. And you need to select orthogonal projection in which you can clearly see the position of your balloon. Then the shoulder will actually push and open the cells in front of the ostium of the side branch. If you have longer length proximally, you should repeat pot, and then you fully open the whole length of the proximal main vessel segment of the stent. And now when we pull this out, you will see that actually going deep inside shows you here that pot opens and widens the distal cells in front of the carina. This is how it looks in the visible heart lab, and you actually under expansion correct with full expansion proximally. However, if your balloon goes too distally, this will shift carina and compromise the ostium of the side branch. Here you see that adequately sized pot. You see here the cells in front of the side branch, distal cells which are fully open. And here is what you see from inside. And we always recommend distal rewiring with the pullback technique. And you see here in red, these cells are actually carina cells. And proximal cells are also not suggested. We have some intermediate cells, and we have really these 2 as optimal distal cells, and we were lucky, so this is the cell that wire was able to connect. If you cross distally, when you inflate balloon, you actually push this metal, and with this metal, you scaffold the ostium of the circumflex, and you will see if you cross distally with kissing balloon inflation, and you see here two balloons with minimal proximal overlap, with distal cell, you see now that actually distal recrossing will push metal, scaffold, and widely open access into the side branch, but this metal will allow you easier the position of the second stent without protrusion inside the main vessel stent. How to optimally perform final kissing for provisional? So two non-compliant short balloons sized according to distal reference of both main vessel and the side branch, short proximal overlap inside the polygon of confluence, because with longer proximal overlap, we elliptically deform proximal part of the stent in the proximal main vessel. So in that case, we should consider doing repot. Otherwise, the benefit of routine repot is not really confirmed clinically, but by imaging and in the bench, repot corrects this elliptical shape stent deformation. What is important, what we learn in the bench does not need to be mandatory, but sequential balloon inflation starting with the side branch first and simultaneous deflation result in the widest opening of the access into the side branch. Here is the latest consensus document from EBC and schematic presentation of provisional, stepwise layered provisional as we used in the EBC main. I just summarize wire both branches, stent main vessel according to distal diameter and do pot. And then you evaluate result. Proceed to the next step if you have suboptimal side branch result. What means suboptimal? Critical side branch lesion with 75 to 90% diameter stenosis, very important impaired side branch flow less than TIMI3, or presence of dissection more than type B. If we have this kind of suboptimal result, we recross distally, open, and then do kissing. And then we evaluate again. After kissing, you can do kissing and stop, kissing plus repot, or after opening of the side branch access, you can just do repot. It's pot side pot that also showed in the bench very good result. If side branch result after these steps is still not optimal, we recommend provisional side branch stenting, which is T, tap, or culotte, or inside internal reverse crush. So you can do various kind of techniques for second stent, and this is not bailout. This is step of the provisional. You just perform and add complexity until you achieve good result. And that's why European Bifurcation Club recommends a layered stepwise provisional more as a philosophy than the way to treat lesions with single stent. So for us, if necessary, having two stents is also provisional, and we just don't try to decide in advance if lesion needs two stents or single stent. Here is the animation which I made again with my colleague, how provisional should be done. Two wires, pre-dilatation left main LAD, stenting of the left main according to LAD diameter, correction of expansion with pot, rewiring with pullback through the distal cell, and then opening and kissing, and then repot staying more proximal. And now when we remove the tissue, you see that following stepwise provisional, we use tubular stent, but we create natural bifurcation anatomy with larger diameter proximally and smaller diameter distally. However, we know from the recent meta-analysis of Di Gioia in JACC Interventions 2020 that decay crush especially has better results in case of diffuse side branch lesion. So if we stratify in this analysis side branch lesion less than 10 millimeters, we don't have advantage of systematic two-stent strategy. However, if the length of the disease of the side branch extends 10 millimeters, you see here, you have benefit of stenting that kind of the side branches. So for us, in the EBC 2020 consensus, we wrote that elective two-stent strategy should be considered for long side branch lesions, high risk of side branch compromise, or difficult side branch access. But when you plan two-stent strategy, it should be done in a provisional stepwise approach, finishing with T, tap, or culotte. Of course, we admit that in certain areas, like in Asia, especially China, India, there are several operators with extensive experience in double kissing crush. So we accept that if two-stent strategy is planned upfront, experienced operator should also use for complex left main double kissing crush. This is the algorithm of the EBC. We try for bifurcations with extensive disease of the side branch, stratify the risk of losing the side branch after main vessel stenting. So if we don't expect high risk of compromising the side branch, we do provisional, stenting main vessel first, and then we do T-tap or culotte. However, if we have major concern regarding the side branch after main vessel stenting, we recommend, if you know how to do good DK crush is excellent option. However, we also recommend, and that's my personal suggestion, stenting from the left main into the circ, then pot, kiss, and then if necessary to put second stent in the LAD, you can do inverted culotte, elective T, or inverted tap. So left main specifically is a different animal because of the anatomical characteristics which are unique for the left main, a wider angle, almost 80 to 90 degrees. Neither vessel is really a side branch because both are clinically relevant. There is area prone to more calcification and fibrosis, and greater need for vessel preparation is recommended. So we expect that two-stent techniques may be even worse for left main compared to other non-left main bifurcations, and ample evidence from non-randomized trials shows also worse outcome for two stents for the two-stent technique. For example, in the Excel, 3-year mortality is also higher with two stenting techniques compared to provisional. However, randomized data from Shaoliang Chen support DK crushing left main. And this is the primary endpoint target lesion failure. And everybody knows this Kaplan-Meier curve that at 11 months, most probably caused by systematic angiographic follow-up, there is sudden increase in the rate of TLR, and this is what actually made the difference. If study was finished just 15 days earlier, you see here that two curves are almost parallel. So primary endpoint showed that in simple bifurcations, according to definition 2 study criteria, provisional and DK crush have similar results. However, for complex bifurcation according to definition 2, which means lesion length more than 10 millimeter and diameter stenosis of the circ more than 70%. Two-stent technique, in this case DK crash, significantly improves primary endpoint. However, I have to say that for Europe, at least for Europe, having 16 millimeter long lesion in the circ is really very rare. And I've been in India multiple times, in China, and I saw that your higher presence of diabetes really has more complex nature of coronary artery disease as well. And I'm aware that you have multiple cases with long diffuse disease of the side branch. So I fully understand that this also drives decision to use DK crash probably more frequently than provisional for that kind of diffuse disease. And also in definition too, the length of the disease in the side branch provisional was 20 millimeters. But in that case, we know from the beginning that this is the lesion which per se requires stenting. And we know from the Benestent and stress that balloon is inferior compared to stent in such kind of disease. So 47% crossover rate in DK crash 5 for me is actually very low. I think that 80% of the lesions in DK crash 5 should have side branch stent in the provisional arm, but not as a bailout, as part of the provisional. And in that case, I'm sure the results will be different. Just few words at the end about our own EBC main study, which was presented last year at EuroPCR and published in European Heart, in which we randomized study to compare provisional versus two-stent strategy. Primary endpoint was broader than DK crash. All-cause mortality, TLR, and all myocardial infarctions at 1 year. 467 patients from 31 centers in 11 European countries randomized patients using Medtronic Resolute tonic stent. Provisional and systematic two-stent approach was according to EBC consensus document, and this is the patient demographics. I want to point your attention to syntax score, which was mean syntax score 23 and 23 in both arms, and procedure duration, fluoroscopy time, radiation dose. Everything was significantly lower in provisional compared to systematic two stents. When we speak about procedural flow, we respected the protocol. 85% of patients had POT, 90% had kissing, and this is the key. If you do stepwise provisional for true left main bifurcation, approximately 1 out of 5 really mandates second stent, but second stent as part of the provisional. This is the indication. Indication for second stent was 10% dissection, 12% residual stenosis. For systematic two-stent strategy, this reflects European practice. Coulot, that I will talk about on Sunday, presented 53% of patients, and T or TAP was used in 33%. So this is European practice, and these are the results. Stepwise provisional, 14.7%, systematic two stents, 17.7%. So study was neutral. There was no harm of doing provisional, and P was 0.34. Mortality was similar, MI rate was similar, stent thrombosis rate was not different. There is some numerical difference, 6% TLR rate in provisional, 9.3% TLR rate in systematic two-stent strategy, and we will keep following these patients and we will see at the follow-up. This is the comparison. Of course, in DK crash, there was better to do DK crash compared to provisional. In EBC main, there was no difference. Study was neutral. Similar result with numerically lower number of events in provisional. And I like very much the Dr. Javier Escaned commentary in the European Heart, in which he says, if there is no really, according to definition 2, complex left main, provisional is good. However, if you see long diffuse disease of the circ as well, in that case, you can either do provisional or you can start immediately if you are experienced with decay crash. How this applies to everyday practice? Stepwise provisional for us is a logical, reproducible, versatile, and remains the strategy of choice for left main. We don't need to prejudge in advance which lesion needs one, which lesion needs 2 stents. You follow the steps, you add layers of complexity as necessary, and you stop when you achieve good result, but you put second stent only when it's necessary. However, we respect that for operators with appropriate experience, decay crash is a valuable option for complex left main. We strongly recommend use of imaging and physiology to guide left main PCI. So to conclude, stenting technique should depend on individual patient's anatomy and operator experience. 2 stent strategies should be considered for diffusely diseased side branch, difficult side branch access, or high risk of compromise. Among 2 stents, there is good randomized evidence to use decay crash, but in the EBC main, stepwise provisional should remain the default for distal left main. I thank you very much for your attention, and I'm ready to answer all your questions.
Thank you, Dr. Goran, for your excellent talk, clarified so many points, and as usual. Now, 2 quick questions from my side. The layered approach which is used in the provisional strategy, when a second stent is required, in the study, EBC main study, we have found that the commonest strategy used was TAP.
Well, culot. Yes. 50% culot, 30% TAP.
Yeah, culot and TAP. The decay crash doesn't come into that picture. How that techniques compares with the 2 stent strategies if you have used upfront in such cases? Is there any data available? Because people find that TAPs may not be a very ideal in many situations. It may be projecting stent more into the left main. Do you have any comments on that part?
Yeah, techniques per se, numbers are too small to directly compare between. I think it's operator preference. What we found is that use of imaging may show some signal that optimization of the 2 stent technique, optimal result achieved with image guidance may improve the outcome, not specific technique selected per se.
So that doesn't matter. The second question
doesn't matter.
Yeah,
yes.
Doesn't matter. The second question is that in the case Suhas showed, he stopped with the stenting from left main to LAD. The result was quite good angiographically in the side branch. If the side branch was compromised, we should have recrossed and then kissing balloon inflation is done. But I have understood from your this thing, in non-left main and left main bifurcations, you prefer to do systematic kissing balloon. Is it true?
This is correct, but only for the left main.
Yeah,
so
for the left
inside
main.
Inside big bifurcation like the left main, what we learned so far is that removing the metal from the ostium of the circ decreases the risk of long-term events. Numbers are small, but we know from Renew Virmani that in cases of autopsy with sudden death or death from myocardial infarction after left main stenting, the major predictors of stent thrombosis inside the left main are malapposition or presence of struts across the ostium of the circ. So not removing the struts was in the study of Renew Virmani that you can find very easily a major predictor for stent thrombosis. And we know from the bench testing and from flow dynamic study that presence of struts across the ostium impairs the pattern and decreases the shear stress at the carinal level. And this increases the risk as a nidus of stent thrombosis. So it's not only my experience. I was trained with Antonio Colombo 20 years ago for 3 years. And part of the standard procedure for me in the left main is to do kissing, but proper kissing with short, non-compliant balloons, not going to very high pressure and not overlapping in the long segment proximally. The role of kissing is first with the overlap in the polygon of confluence to correct malapposition. This is the key in bifurcation area to oppose the stent well. And second, simultaneous inflation of two balloons puts carina in the center, which is the key for the normal pattern of flow. In non-left main bifurcations, I don't routinely do kissing, only if side branch is compromised.
Thank you. Questions from the panelists? Deepak, any more this issues on this before we conclude?
Yes, so we used to wonder why in EBC main it was mandatory that you need to have a kissing balloon dilatation of the left main bifurcation provisional strategy. Now we understood that you mentioned that through Dr. Renu Virmani's studies, having struts across the left circumflex ostium can lead on to thrombosis. So we understood that point. So do you think that in the case that we saw earlier, the case in the box, we all felt that it was a perfect result at the end of the day, but would you still go ahead with a recrossing into the side branch and do a kissing balloon dilatation in that sort of results?
I think result was perfect inside the left main, but there is no plaque in that area. In this case, we don't have absolutely any evidence. In this case, stenting of the left main was not done because of disease. It's done in order to fully cover the ostium of the LAD and to cover some small protrusion of the plaque inside the left main. So I'm not convinced that we have clinical benefit of routinely performing in completely healthy circumflex, healthy distal left main. I'm not sure that doing kissing will improve more the result.
Sir, how about your experience regarding side branch dilatation with DEB? Because nowadays we are using, whenever we are using kissing balloon, particularly when the block shift that is there instead of regular NC, we are using side branch DEB.
Yes, thank you for that question. I think this is one of the most frequent questions in bifurcation webinars. I like the idea. EBC supports development of randomized study to document the benefit of such strategy. We are working with multiple companies trying to collect all the centers which would like to participate in such endeavor. And until now, we have 3 parallel randomization projects that we are running in discussions with companies. So we will come very soon with the proposal for the next study with DEB in bifurcations. Problem is with the support, companies are really not keen of working on a study which will demonstrate non-inferiority or QCA confirmation of less restenosis at the ostium of the side branch. So I think until next TBC meeting in October, we will most probably come with the proposal for randomized study.
Sir, how about the post LMPCI FFR post PCI FFR strategy, particularly if they don't have an imaging? Left main is very crucial. It supplies the maximum area of the left ventricle. Do you recommend post PCI FFR to maintain the FFR value of more than 0.8? Anything?
Yeah.
In your experience?
This is excellent question. We will come very soon with a joint consensus document on physiological indexes for left main and bifurcation PCI. We prepared that consensus document with Japanese and Korean bifurcation club. So it's joint project of European Bifurcation Club, Korean and Japanese. In that one, you will see our algorithms and suggestions. Clinical relevance of the side branch is very important aspect, and crossover stenting with the evaluation with FFR of the significance of narrowing of jailed side branch is part of recommendation. However, not a parameter on which you should base routinely decision whether or not to proceed with opening of the struts.
Dr. Goran, the Chinese had come up with a technique called the railroad technique, where you keep a side branch balloon inflated across the ostium of the side branch while you deploy the main branch stent. So is there any studies which you are looking into it, or?
This kind of inflation of balloon in the side branch is not part of the EBC philosophy. So for us, we don't really, okay, I will speak on behalf of myself. I don't really see any potential advantage of routine inflation of the balloon with deformation of the stent, which you afterwards need to correct. In case of very tight and diffuse lesion of clinically relevant, for example, circumflex, if the operator feels fear of losing the side branch, I will understand to use jailed balloon instead of jailed wire. But routine inflation of the balloon, I don't think we have enough evidence to justify that strategy.
Thank you. Thank you.
So there are a couple of questions in the chat box. One is, while doing a provisional strategy, if you were to convert it into a two-stent strategy, what is your preferred strategy? Is it going to be a tap, or is it going to be a conversion to culotte? That's question number one. And the second one is, let's say you have a isolated ostial circumflex stenosis, tubular stenosis with normal left main and LED angiographically, what would be the stenting strategy?
Okay, thanks. Again, two great questions. Selection of the strategy, first is operator preference and experience. Second, angulation. If the angle is 90 degrees, culotte overstretches the stent, and culotte is not good for wide bifurcation angles. If bifurcation angle is narrow, culotte is excellent, but mini culotte, not really full coverage in the proximal part. And for us, recrossing point into the side branch actually determines strategy that you will use. If you cross distal cell, you project some metal at the ostium of the circ. So when you pull back your stent from the circ into the left main, you don't need to extensively protrude to fully cover the lateral wall. In that case, you can even do T, not even tap. So less protrusion for us philosophically is better, but it's very important to make sure that you cover the ostium, okay? Second question, so either T-tap or culotte, I think there is no difference in the result unless you don't optimize. It's more important to optimally expand both stents than which technique you will use. And second, for isolated ostial circ, nobody has answered which technique is ideal. What I will personally do, and what I did for EuroPCR, I did 2 live cases. It's always crossover stenting from the left main into the circ, image guided with pot and kiss. In case of optimal result, I don't stent LAD. But if the result is not good, even if there is some narrowing, then T or tap.
Sir.
Yeah, I think wonderful discussion, Dr. Goran. I think
It's
thank you
always
very much
pleasure
for being with us.
Whenever it's Indian webinar, I enjoy very much discussion, and people are so nice and polite.
Most welcome, most welcome. Yes, we are highly grateful. Deepak?
Yes, sir. Shall we move on to the next session? So we have three case presentations. The difficulties that that were encountered during a provisional strategy by Dr. Jaspal Aneja. He's from Nagpur. He's a chairman of Aneja Institute of Cardiology. Then we have Shivprasad sir presiding the second case. He's the head of he's the professor of cardiology at Trivandrum Medical College. And then the third one by Dr. Shivkumar, who is the senior intervention cardiologist at Madurai Meenakshi Medical Mission Hospital.
Dr. Jashpal, you're on.
Yeah, sure. Thank you very much, Dr. Davison, for asking me to share a case, a sort of a complication that we encountered during provisional stenting. This patient is a 50-year-old gentleman, had an anterior wall MI 7 days back. ECG showed an evolved anterior wall MI, an ejection fraction of about 40% with preserved thickness of the LED territory. The renal functions were nearly normal. And this is the angiogram that you see. You see that there is a short left main, there is a dominant circumflex, and there is a LED which has osteoproximal lesion and possibly a plaque extending into the left main on the superior surface, and the LED is totally occluded. And this is a diagonal, that you can see. So it's a totally occluded LED, osteoproximal lesion. Obviously, we are considering angioplasty. When we are considering angioplasty, as we have already discussed, our approach is going to be a provisional approach in this patient, and imaging would always be, helpful. So we crossed into the LED with fairies. This was a recent occlusion. Open it up with a balloon to make passage, and this is what we see. We see that the LED is a little diffusely diseased, the disease extending up to the mid LED, and no good, landing points were really very, very clearly visible. So we did imaging with OCT to assess the plaque burden, to assess the distal landing points, to assess the size of the ostium of the LED, and to see whether the disease was extending into the left main from the LED. And, as you see here, the distal landing zones were reasonably all right. As you see on the image on the left-hand side below, there was a tight lesion in the ostium of the LED, and the LED was about 4 millimeters at the about 3.54 millimeters at the ostium, and there was a significant plaque into the left main, that is you see on the right-hand side lower image. You see the circumflex originating from the left main, and there is significant plaque that is seen extending into the left main, which we usually see in most such patients. So, as per plan, we prepared the lesion well, and then we have taken a stent distal to the from the distal end of the lesion into the proximal LED, and then having done that, we took a short stent from left main into the LED. So this was a 4/12 DES into the left main, and at nominal pressures this was deployed. And you see, after this, there is some plaque shift into the circumflex. So although this was an appropriately sized stent at the ostium of the LED, as we were discussing, what size of that stent we should use when you are coming from left main into the LED. Now, if you oversize the stent at the LED ostium, then there is a chance of plaque shift that can happen into the circumflex artery. So, but this was an appropriately sized stent that we saw on IVUS, that the proximal LED was about 4 millimeters in size, but this was what we saw. And so the plan here was to do a pot, and as discussed, a layered provisional strategy, the next step was to recross and do a kissing inflation, and then see if kissing inflation looks good, we could end the procedure there. And if it doesn't look too good, then we could always add on to another stent, either by a tap or by a culotte, as discussed by Dr. Goran very beautifully. So we did a pot with an appropriately placed balloon, as you see here, which is very, very important aspect of the pot, is to have a balloon, maybe right up till the carina, so that you oppose the stents of the left main into the side branch. And so having done that, we, as discussed again and emphasized every time, when you're doing a provisional strategy and when you're doing a final kissing in a provisional, you would try to do a distal cross, as you pull back. That's what we, tried doing it from coming back from the LAD and going into the circumflex. And, you see here, we tried to do a distal cross, although there was a very clear lumen which was available here. And after that, we, got the balloons across on both the sides, optimized the LAD. And as we were positioning our balloons from in the LAD and the circumflex, we realized that everything is not well at the ostium of the circumflex. You can see there was no lesion here initially. There was a little bit of a carinal shift at the ostium of the circ, but now you see that there is a significant narrowing of the circ, and the flow also is not very great. At this point, the patient did develop hypotension, because this is a left dominant circulation. This is a recent entry-wall MI, so the circumflex flow is of real great importance to this man. So we were not very certain what's happening here, what would be the cause of this slow flow. And so our thought was whether it is, a very significant spasm that has occurred there, or a thrombus which is not really visible, or have we created a dissection to the circumflex and which has extended distally. So with these three thoughts, we just went ahead and we gave a lot of, and at this point, we gave a lot of vasodilators, but at this point, we realized that there is some dye staining here. So, and dye staining here, which told us that yes, we possibly have created some dissection while crossing. And that possibly occurred while we were trying to go it from a distal strut. So, so, this was a time when patient was actually developed a significant hypertension, was on inotropes. So we thought we'll just go in and put another stent from left main into the circumflex. And that's what we did. As you can see, we got a stent closed and we were planning a tap, but as the patient was not really hemodynamically very good, we just inflated the stent, and we didn't have time to get a balloon into the LAD, to place it across the stent. And as we placed this stent, see the stent has come slightly into the left main, so it's not really a tap, here. But then, nevertheless, having done that, we realized that the flow distally is still not good, and patient was again, not doing very well. We got this balloon out, put in a thrombus aspiration catheter for a targeted vasodilator therapy, or if there was a thrombus, to do some suction. We did that. There was some flow, but again, the distal, right from the distal at the edge of the stent, we were not, the flow wasn't too good. And these are shots taken with that thrombus aspiration catheter after we gave targeted vasodilator therapy. So again, again, our questions were whether a dissection is extending distal to the stent, or there is a thrombus distal to the stent, or there is microvascular clogging, So, here, since we were not certain, we decided that we'll go ahead with imaging to see what's happening, distal to the stent. And any thoughts from the panelists or from Dr. Goran on what could be happening distal to the stent?
May I discuss this case?
Yeah.
Actually, this is a classic case of intramural hematoma.
Yeah.
If you see the IVAS image, the LAD ostium is a fibrotic lesion. Normally, when you do the simple balloon dilatation or with the stent over expansion, that time LCX appears to be fine. When there is a junction of the diseased segment with a normal segment, when you do that one, the hematoma extends into the, there should be a normal segment to extend the hematoma. If a diseased segment, it will not extend. So initially, you can see the clear-cut radiolesioncy at the ostium. In such cases, always, even I encountered these type of patients, particularly when you see the LAD ostium more of fibrotic lesion, it's always preferred to do the angiosculp or cutting balloon. Suppose already you have put the stent, at least LCF should be redilated with the angiosculp so that you can empty the hematoma. Otherwise, what happens when you put the stent, it will squeezes the hematoma distally and again it closes. It's like an oil seed effect. So where there's a pressure less, because this entire L6 is a normal segment, so it can spread easily. Assume that here mid L6 is disease, it will not spread. So the intramural hematoma behavior, it should have a normal trilayered structure so that it can spread fast. So you can see this is not spasm, this is a classic. If you see the IVS or OCT, 100% you will see the intramural hematoma.
Yeah. So here, I think Dr. Sridhar, you were spot on. So we just wanted to make certain, that our wire is, in the true lumen distally. So we just changed the branches, and we were very certain that yes, we are in the true lumen, and and then we did imaging again, and here, it was confirmed that we are dealing with the intramural hematoma. As you see here, there is a dissection, and then here, and there is an intramural hematoma. So this and causing luminal compromise. So there was a dissection plus an intramural hematoma, as you see on the OCT runs. Distal. There's some dissection distal to the stented segment, and then we just as you said. Now we have two options. One was we empty the hematoma using an angiosculp or some sort of a cutting balloon or a scoring balloon. But since we saw dissection already there, we thought it's a good idea to just, gently stent the entire area. So we took another stent, overlapping the proximal, going into one of the branches. And having done that, everything seemed to have resolved very well. We optimized it, and everything looked, very well. And then we corrected what we had done here. We recrossed and converted this into a sort of a mini or a micro culotte, and finished the procedure after adequate post dilatation and everything. So it was basically and we did then OCT of the IVS again, and confirmed that that the distally the stent was all well opposed, and there was nothing and it was well open. Obviously it was a normal circumflex, so we had compressed the intramural hematoma to get a good lumen. And these were the final images. And so I think the problem started here while, attempting to cross through a distal strut as recommended. We went subintimal there, and then created a path where, as Dr. Sridhar suggested, that we, then since being a normal circumflex, the intramural hematoma extended till further down. And we fortunately, did a 6-month angio, and the patient is doing very well. After 6 months, everything flowing nicely and well. So this was an avoidable complication. I think, so when there is a carina shift post stenting in a provisional strategy, I think, many available strut is possibly good enough to recross and do a corrective kissing balloon inflation. And while deploying a left main to LED stent, I think we need to remember two things to prevent carina shift. One, stent should match the size of the LED ostium and not oversized, because then you could cause carina shift. Second, we should be deploying the stent in nominal pressures and then go aggressively with non-compliant balloons, so that you don't overstretch this stent at the ostium of the LED. And in a dissection, always confirm and reconfirm that your wire is in the true lumen before you stent it. I think So, although in provisional stenting, we see this sort of carina shifts, which are very easily corrected by doing a final kissing inflation. And especially if your the circumflex ostium is normal, and you could correct this and get a good result. It was only because our wire went subintimal and we went subintimal that we created a dissection and intramural hematoma, which compromised flow into the into a dominant circumflex and an infarcted LED. Thank you. We could have some questions on this.
Jasper, what's the wire you used to cross the circumflex? Usual.
Our workers' wire is a cyan blue wire. So it was a cyan blue wire.
This is many times happened with even with senior cardinals, particularly short segment LED. It looks like a classic type A juicy lesion. But when you do NC, immediately the hematoma will go and occlude the LMC and it extends to the L6. That is our practice. Most of the time, these are more of fibrocalcic lesion. The calcium will be less, more of fibrous. And the remaining vessels will be, surprisingly, entire vessel will be normal. So when the normal zone is there, when you go with the regular NC, what happens, at the junction of the normal segment and the disease segment, that creates a dissection because the normal layer is there, the hematoma will spread easily because it separates the layers. But if the disease segment is there, diffuse disease is there, it will not spread because that is going to arrest because the media has to be free to spread. So whenever you go with high pressure balloon or stent expansion, because we are squeezing the hematoma. So where it will go, proximally it can't go because already stented expanded. Distally, because it's disease free, again it will. The two of the recommended treatment options were intramural hematoma, putting additional stent with a long length. But sometimes there is a risk of expanding the stent and going distally and uploading distally. Always best thing is to do the cutting balloon or scoring balloon and inflate sufficiently so that it creates a incision so that the belly will be decompressed. So that time you put stent, many times it will not spread. So most of the time, if you see the after a L6 compromise, if you do the OCT, 100% that will show the intramural hematoma, compromising the L6 ostium. That time, if I am doing the case, I would have done definitely putting the cutting balloon, dilate it, and subsequently put a short stent.
So even to prevent this osteal dissection of the circumflex, I think upfront using a scoring or a cutting balloon for the LAD fibrotic lesion would have also possibly.
Yeah, that's the best recommended strategy. That's the reason when I see the osteal LAD fibrotic lesion, this cutting balloon is the best.
So possibly the hematoma started right after the LAD pre-dilatation with a non-compliant balloon at high pressures.
Yeah, that's the right thing.
Which compromise in the first place?
Yeah.
One more point to add, Dr. Kasturi, for the hematoma. With the availability of imaging and promptly done the imaging, especially OCT, you can find out the advancing edge of the hematoma distance.
Yeah.
And if you are sure about that, you can measure the length of the stent and place it. We have done it like that. Hematoma is identified and the advancing edge of the hematoma could be clearly visualized by OCT. I'm not sure about IVUS in that, but OCT clearly shows that. And a stent could be used to cover the entire hematoma.
So when you're not very sure whether it's a dissection or a intramural hematoma, will having an OCT done, will that further worsen the situation if it were to be dissection?
Normally, intramural, like a spontaneous coronary artery dissection, there are recommendations. Ongoing pain is there, ACS picture is there, cardiogenic shock is there. You are not supposed to use, only use the IVUS. In such circumstance, it will further deteriorate. But stable patient where they have a proximal exit point and even inferomedial, suppose already free flow is there. That means already exit point is there, entry point is there. So that time it will not spread. So stable patients without any ACS presentation, in such patients, they have done the OCTs. And many times they are saying OCT, no need to extend too distally, just only proximal portion you take. You see the entry point so that you can identify the etiology very clearly. But ACS cardiogenic shock or unstable patients, not to touch with the OCT, IVS is the best measure to do that one.
Dr. Arnej, how you got away from your case? It was moved from, after sending the proximal L6, moved to the mid L6. Finally, what you did? How you finally got away from that?
So you're talking the stent coming into the min, no?
No, after sending the proximal LCX, your intramural hematoma moved to the mid LCX.
Yes.
And finally, how everything got settled down?
So
what did you do?
Once we identified that, we stented it distally from the with an overlapping stent into the next. We took a longer stent this time and covered the entire hematoma into the normal segment as we discussed, and that after that, everything sort of settled down.
And one small comment, even after stenting with use the second stent, better to do a further imaging, confirm that it's not extending further. There was an instance in our place, we had to put 4 stents, it just extended up almost up to distal LAD. And another thing, always better to extend beyond a branch. So branch point is where all the 3 layers come together. So it's always better to extend beyond a branch and not aggressively post-dilating the stent. So all these things may avoid extending the hematoma. And as Paglian sir said, if we had confirmed in the first instance the extent of hematoma, you would have got away with the single stent. Maybe a bit longer stent, I'm not sure whether that would have tracked, but would have got away with one stent.
Right.
But it is excellently
when
managed.
you tried to cross the side branch, it was looking like too distal.
No, that is what he was discussing. That's what all the problems have happened. But it was excellently managed.
So we went into a branch, after that, into the circumflex, into the branch, so that we covered a longer segment into the branch. So to be very certain that we have taken care of the distal part of the hematoma, which was actually, I was also confirmed that it's not extending into the 2 branches. So we went beyond that branch and covered it.
Right. Usually the hematoma stops at the branch points, usually, but not always, because all the layers come together at the branch points.
No, I'm talking about the side branch crossing. It was looking like too distal cross.
Yeah. So on angiogram, it's very difficult to decide whether it's a distal cross or a distal cross. So angiographically, you would always like to go for a distal cross. But then, going by hindsight, I possibly thought that it was what happened was the hematoma was already there, at the osteoid, which was causing this compromise already. And I'm not too certain whether the wire has done it or the hematoma was there right from the beginning once we had pre-dilated the LED. Because these hematomas sometimes may not be visible very well angiographically unless they are causing luminal compromise.
Yeah.
Any particular reason for
Dr. Praveen?
Any particular reason for not keeping a wire in the dominant circumflex before you stent from the LAD to circumflex?
I was sure this, somebody would point that out. It was an absolutely normal looking circ. It was basically no other reason. Ideally, we should have always put a wire into the circ, but it was an absolutely normal, good size 3.5 millimeter plus sized circ. So it was, just we didn't put a wire into the circ, but that's not, one should always be doing,
And also while doing the tap, I didn't see a balloon in the main vessel.
So that was,
I think maybe
the patient was actually crashing at that time. No time.
That is understood.
So we just got a stent across that, and we just got that.
Okay.
And we obviously later on it became like a mini pilot rather than a tap, and we did we decrossed and did a final kissing at the end of the procedure.
But I think wonderfully managed, despite so many issues, because the sticking to the procedure, that's the most important, not to lose temperament and not to give up. Many times you will overcome, but I think nicely managed, beautiful.
Yeah.
Bagalan sir, you're muted.
I think we can move on to the next presentation. Dr. Shiv Prasad.
Sir, we cannot hear you, sir.
Am I audible now?
Yes, sir. I think your laptop only is picking it up.
Yeah. Can you hear us?
Your voice is very low, sir.
Voice is feeble.
Very feeble. Just go into the audio settings, see if you're on the right microphone, sir.
Yeah. Yeah, can you hear now?
No, sir, we can hardly hear you. Can I give a suggestion? Can you remove the earphones?
Hello?
Just disconnect the earphones. Go with the laptop, if it's a laptop.
Can you hear now?
Much better, sir. Sir, we can hear you loud and clear, sir.
Can you hear now?
Sir, no, sir, it's gone again. Once the earphones are out, it's all okay, sir.
Yeah.
Can you check your microphone, sir? No? Oh, I think his laptop is not able to hear us.
Hello?
Yes, sir. We can hear you loud and clear, sir. No?
Is it better?
Much better, sir.
Yes, sir. Yeah.
Yeah. Can you see the slides?
Can we go to the slide
Yes,
show?
slides are very well seen.
Can we go to the slide show, please? Full screen?
Can you see the screen?
Sir, they are on sorter view. Can you go to full screen, please?
I think your audio is not very clear for me now.
Hello, sir. Can you go to the full screen slide show? The bottom right hand side.
Yeah.
Yes, sir. Perfect.
Yes.
Can you hear?
Yeah.
Yeah, shall I start?
Yeah, sure. Yeah.
Yeah. This is again another case of provisional stenting. I think. Yeah. This is a story of a 49-year-old lady who is a diabetic, was admitted 3 months ago with anterior wall myocardial infarction and came with class 3 effort angina, and angiogram showed a long segment LED disease which involves the LED D1 and lesion distal to that. The lesion, LED proximal lesion is Medina 111, and these are the salient highlights of the lesion. It's a true bifurcation lesion, Medina 111, and the side branch size was less than 2.25, maybe around 2, and side branch disease is less than 10 millimeters with 80 to 90% diameter stenosis, and there is another distal lesion, and the angle is around 80, and main vessel disease extended more than 25 millimeters. Our thoughts were, should the side branch need to be preserved? We are doubtful. We thought this is a small side branch and may not affect much. Is there any likelihood of side branch occlusion? Because there is significant, nearly 90% osteal stenosis, maybe it may get compromised.
Recording stopped.
Hello?
Sir, you can carry on, sir. Sir, you can continue, sir.
Yeah. So we decided the strategy of professional stenting, and we pre-dilated the lesion and pre-dilate the distal lesion and the proximal lesion, and the side branch was also dilated because it was 90% stenosis. I was afraid that I will occlude that small diagonal. Then we proceeded with stenting the distal LAD with 2.75 to 38 millimeter sirolimus eluting stent was implanted, and then the proximal proximal lesion was stented with a technique of keeping a balloon inside the side branch, a smaller balloon, 2 millimeter balloon, and which was inflated at 4 atmospheres, and the main vessel stent implantation 8 atmospheres was done, and then the side branch balloon was withdrawn. And after this, see, that is the first picture is the picture after the implantation. You see the side branch is flowing, Dimitri flow, but there is some ostial stenosis. We are happy with the result. Then we recrossed the wire and post-dilated the lesion after rewiring with using 3 into 14 atmospheres proximally with NC balloon. Soon after the dilatation, patient had ST depression and angina, and this is a post-dilatation angio, which showed a total cutoff of the side branch. Initially, I thought the side branch is of not that much importance, but the patient had continuing angina, she was restless, and there was ST depression. This was the mixed feeling which I had with the vessel, which I thought that I will not harm the patient. After occlusion, developed symptoms. Now, then we dilated the side branch ostium with the balloon 2 into 10 sapphire balloon, and after the dilatation, the flow was not better. Still, there was compromised flow, so we decided to stent the side branch with a tap technique. This angle was almost 80, so we decided to stent with the tap technique, and this is the simultaneous kissing dilatation after the implantation of the tap, and final result shows excellent flow in the diagonal as well as the main vessel, and the patient's symptoms disappeared. These are the series of final pictures which shows good flowing diagonal, and the patient had absolutely no symptoms. What I learned was provisional stenting, though simple, it's a beautiful strategy in bifurcation disease where chances of side branch occlusion or consequence of side branch occlusion is expected to be minimal. But even a well-planned provisional strategy has the potential of side branch closure, though it occurs in a few. Even a small side branch can be important when compromised, causing ECG changes and symptoms as in this case. Balloon embedded technique, I believe, helped me in recrossing, rapid rewiring the side branch subsequently. But this is not a routine practice for me. In cases where side branch occlusion happens, pre-placement of side branch wire before the post-dilatation of the main vessel stent helped in intervention to improve the side branch flow. And if the side branch flow is suboptimal even after balloons dilatation, stenting of the side branch may become necessary where either tap or reverse crush or pull-out can be used. Thank you.
Sridhar sir, Shivakumar.
Yeah, Shivakumar, you want to comment?
I think you can start. Anyhow, I have a presentation.
This case, we have to assess when diagonal branch is there. There is new score. That is Seoul National University Hospital score. We have to see how many diagonals. Is it 1, 2, 3? And beyond the lesion, is there any another major branch is there? Here, if you see only one diagonal. If one diagonal is there, score 2. If 2 diagonals are, score 1. If 3 are there, 0. That means if more number of diagonals are there, if one of the diagonal is closed, nothing will happen because other 2 are protecting the lateral area. And if you see that beyond the lesion, there is no other branch. Other branch in the means diagonal. There is no other septals are there. There is no major. So that comes under highest risk. So if you see the entire LAD, though it appears to be small, maybe diffuse disease, but that is important with a large vessel and is almost length is long. They have assessed even CT assessment of the length. Is it supplying more than 10% of the myocardial area? Definitely that is important area that supplies more than 10% if you calculate based upon the CT assessment. That is very important area. So that time, always we should take care of the side branch in stenting. I know how you have managed very well. And in such case, I also do like a, though it's very small, if I don't want to do any additional stent, I use the gelled balloon technique. Very thin profile 1.25 balloon, keep it there, stent it, and if most of the time it's very well preserved, you can pull it. If that is the slight dilatation, part and recross and do it. I think based upon SNU score, that is very important vessel, particularly when we consider the diagonal for reperfusion, but managed nicely, and both vessels are very impressive. Congratulations.
Sita, your points are well taken, and it is not my routine practice to put balloon embedded technology for side branch protection. But in here, I thought I may not have to do anything to the side branch. Finally, I ended up with stenting the side branch, which I did not want to do.
Yeah.
Ravi.
So very well done, guys, sir. Nothing more to add. I think you tried to preserve the branch initially when tried to go for a provisional strategy, but finally you had the branch occluded and you finally managed to open it up well and with a very good result. Nice result.
Sir, we were very fortunate that this closed down only after rewiring into the side branch and when post dilatation was done, isn't it, sir?
Unmute.
Before.
Shiv Prasad sir, we cannot hear you when you plug in.
A port before rewiring, what I do is I withdraw the wire from the LED, distal LED, and before taking the wire out, I try to enter through the distal stud to the side branch in all my bifurcation cases. But I know the recommendation guideline is mandatory port of the proximal if you're using a wire and you're entering from proximal to distal. Or either you should enter with a loop otherwise. But if in a roomy proximal vessel, you are very likely to get entangled between the struts.
So, but here in this particular LED, the distal LED as well as the proximal LED was of same caliber. So is it really mandatory to have a part done before recrossing into the, because almost always the LED stent would be approximately well into the in the proximal LED also.
Not hearing you. Actually, there is some problem with probably my computer audio. I'm not hearing you. Can you please repeat the question?
Yeah, just a second. Just a second, Deepak sir. Right, sir. You can plug in for hearing. Remove it while talking, sir. Shiv Prasad sir, please plug in for hearing. Yeah. Now, please go ahead, Dr. Deepak.
Sir, in fact, in this particular vessel, the proximal as well as distal LED was of almost similar size. So would you really want to do a part in these situations? Because the stent in the LED that's crossing over the diagonal into the proximal LED, it's almost always well opposed to the vessel wall. So would you really want to have a part? I mean, when you have a huge mismatch between the distal vessel and the proximal vessel, always part is mandatory. But here in this situation, is it really mandatory?
I also felt the same way, that the proximal stent is already opposed very well to the vessel wall. And probably pot is not mandatory in this case.
But I think other way around, because whenever you see the Finet's law or Murray's law, always we have to see the side branch diameter and the distal diameter. And based upon that, if you calculate it, definitely, though appears to be uniform, but we have to consider the daughter vessel size also. When you see the daughter vessels and the main branch, definitely proximal to that bifurcation, it will be bigger. Sometimes because the diffuse disease, it may appears to be uniform. But the actual size of the vessel, definitely it will be bigger. So part has to be done not only to increase the size, but also to open the side branch struts. So side branch strut will be opened so that you can enter into the side branch struts very easily. Otherwise, even if you are not doing also, the flow will be established. No need to recross and do the kissing also. That is the purpose.
No, I also agree with Kasturi, Dr. Kasturi, that a port is really to be done, because the angiographic dimension which we see may not be the correct one, especially in the LED after the giving of a branch. Imaging has shown that the proximal size will be different, and port has got different advantages which has been enumerated.
So just a small question on this particular point that you mentioned, sir. So the vessel size, the diagonal ostium was too small. It's a small vessel. It's almost compromised ostium. So don't you have the scare of compromising the flow into the diagonal while doing a pot? Is there a small chance that we might totally occlude, because we always want to try to position the balloon just proximal to the carina? Certain balloons, it might grow proximally and distally a little bit, so that will that really be, we always have a concern. Let's say it's a left main and a huge circumflex ostium, definitely we are almost sure that having a pot, you are not going to compromise the side branch. Here it's hardly 2 millimeter diagonal branch. Our intention would be to splay the strut into the diagonal branch while doing a pot. That is one reason why we do pot. So while doing that, is there a small possibility that we might compromise the side branch and it gets totally occluded? So, what would be the answer for that question?
My argument would be in a different way. If we dilate as the post dilatation, despite without conservation of pot, starting from distal to the branch and proximally, chance of compromising the diagonal is much more than giving a pot. So I would definitely place the stent and the guide wire in the side branch and do a pot, and then only go for subsequent procedures.
The pot is almost always done with a jailed wire.
Right.
So,
it's always. Yeah. And in fact, Shivakumar, that point before this meeting ends, we should make it very clear. In the left main bifurcations, the wire has to be there, as Goran mentioned, while the pot is being performed. The wire gives a lot of advantages while we place the pot, because correct placement of the distal marker of the balloon just in front of the carina, not at the level of the carina. This is also very important. Otherwise, you may enter into the distal LED and the LED will be overexpanded. Actually, it should be just
when you do it on a jailed wire, as rightly asking by Deepak Davison, even if the branch is lost, now the wire is a road map to rewire it. And in the extreme case, worst case, you need to go through that jailed wire and rescue it is a dominant LCX, like Adnaja's case. Sometimes hypotension.
This problem is because even among very senior operators, we find a difference. The other day, I was seeing a case where John Fajade mentioned that when you have a long wire to be jailed for a diagonal distal down, it is better to remove the wire, especially in calcified vessels. So still there is some difference of opinion with regard to there. But with left main, it is always better.
No, that point is very pertinent, sir.
Yeah.
Well, sir, all these recommendations are basically for LM bifurcations. Can we directly apply to the small vessels, like Dr. Deepak has pointed out? This is barely a 2 millimeter vessel with an ostial disease. If we do not pre-dilate, I was afraid that I will definitely compromise the vessel if I dilate and put a stent in the LED.
Yeah, that takes us to the definition of bifurcation. If the side branch is 2 millimeter, well, does it satisfy to call it as bifurcation? It has to be at least 2.5 millimeter.
Yeah, but then here I also thought in the same lines and scientifically performed procedure. Finally, I found that the patient is struggling.
Now, I think over the last several years, this has been my practice. Place the stent across the diagonal, do a nice pot.
Anyway, after this, I do routinely the mandatory pot and then only try to recross.
Yeah, that's right. Okay.
Deepak sir,
but sometimes diffuse disease underestimate the size of the vessel. See, diffuse disease, the ostium, we may think it's a 2 mm, but the actual size will be much bigger, because that is the only one diagonal, no other diagonal. And that is a long length is there, and distally there is no beyond that. But before that, at least osteal lesion is there, at least imaging, see the size, if it is a 2.5 or not, or adequate nitroglycerin, and see the size, then we have to decide.
Before leaving the session, can I ask one question to all the experts in imaging and others in bifurcations? We do the imaging for pullback from the main vessel to the for proximal one, and try to look at the side branch ostium, how the stent struts are covering the side branch ostium. Is it really of any clinical value? We hear a lot about linked carina, crowding of the struts across the side branch. How do we react to that? Is it really mandatory? After especially, I think Dr. Kasturi, Dr. Vijay, Shiv Prasad, Deepak, all of you, Shivakumar, all of you are doing it. Does it make a point to look at it? Because the case today demonstrated in the live-in box, it was a stent across. We have seen similar good results, and the patient coming back after 6 months to 1 year with ostial circumflex stenosis. Very good first result. I have gone back and looked into the first result. It was good. But at that time, it was not looked carefully into how the jailing of the side branch has happened. What is the pattern of the jailing?
Actually,
the Japanese group discusses this always. Vijay, what is your comment on that? Should we really look into that? And should it make it a serious matter to react to that? If there is a linked one, separate it out. If it is very non-linked, you leave it.
I think there is a study going on in Japan, so we'll get the answers soon. From 600 patient study. So OCT based for physical balloon dilatation and provisional strategy. Most probably will, but till that time, I think the only one study we had from Korea long back, which has shown that whether you do kissing balloon or not, the outcomes are not going to be different. Because they say that by doing a kissing balloon, if it is not favorable morphology of stents, you are increasing the chance of main vessel stenosis in the future, even though you improve the side branch outcomes. And that equals out the patients with coming back with side branch stenosis of covered stents. And another thing, suppose if it is due to covered stent sets, and even later you can just dilate it and put regular kissing balloon dilatation, that should work.
Yeah.
What do you people think? Rather than going with the kissing balloon dilatation to start with.
Just dilate with a small size balloon. Yeah.
Balloon, and then you do a kissing balloon.
Kissing,
That
is a port side port.
Yeah. If you have any concerns, and we can even use the kissing balloon at that time.
I think it's a great question by Dr. Bahule. What are the findings you get when you do a pullback from main vessel to distal main to proximal main vessel in the side branch? It could be strut-free Karina. It could be struts with a link-free and struts with a committed link. The Japanese group invariably says, please see that if it is strut-free, do nothing. If it is link-free, just distally cross, do a case. If it is committed link, even junior side promotes pushing balloon technique. I think I agree with Vijay Kumar that we need to look into Illumian 4 data and October trial, and also doctors, the bifurcation arm is going on. As rightly asked by Dr. Bahulayan, by doing all this, are you going to really benefit? Because now we are going to pushing balloon, we are going to trauma. So leaving them as such and creating a mechanical force and playing with them. And Sridhar Kasturi asked, drug-loading balloon versus non-drug-loading balloon. So these are all coming into mind. Until otherwise somebody does angio-guided, looking into all these three factors and specifically taken a decision, strut-free, left-it, link, committed link, pushing balloon. I think this is tough to do trial. If you grossly take two arms, angio-guided and OCT-guided, then maybe somebody address these issues, maybe you can come to a conclusion. Otherwise, he has to do very meticulously angio-guided, OCT-guided, again OCT-guided, reacted, not reacted. Otherwise, this will be tough.
Randomized data also is going to be very difficult. Most of these observations from imaging are having observational or registry data, and that is one of the problems. Kasturi, any comments?
Yeah, as of now, there is no supportive data because the provisional stenting, they have one study, routine kissing, they increased mortality. MACE rate is more. But only like when they have given clear-cut guidelines, like a TIMI grade 3 less than, or side branch stenosis more than 50%. So in such case only, they recommended kissing. But as of now, like a routine kissing, associated with more MACE rate, we are not supposed to do. But as the like a Kubo group where they mentioned OCT, when they did some struts are across, they could found some double meatus, bridges across, endothelial branch. So because that they thought that eddy currents may produce more ISR rate, but there is no supportive data, no randomized data. Only it's individual choice, and what they are recommending, smaller balloon, just separate studs, not to touch the endothelial wall. That is the with low inflation. But how far it is going to help, we don't know.
So thank you very much. Thank you, Deepak, for your this opportunity. Thanks all your friends for the interview. Thanks to Shiv Prasad for a nice case. Thank you.
Sir, we have one more talk to go.
I think Shivakumar talk is there, no?
Yes, sir. We have one more talk to go, sir.
Just I will make it. I know it's 9:45. Dr. Bahulayan, if you have time to stay with me, or if you're
I would love to hear you. I would love to hear you. Yeah, please go ahead.
You can listen to me on dinner on plate.
Right. Okay.
Keep
questions are reserved to the end.
Shiva, you don't have to rush through, Shiva. We'll be with you till then.
Okay.
So just,
Shiva.
I know it's 9:45 and last lecture.
I think people will say that that's why they kept your talk as made this way.
Right. At the outset, I thank Davidson. I call him Dibu to keeping this special bifurcation series all about the provisional DK and QLAT and keeping me as a speaker on this provisional in particular as day one. Let me take you all through in another 10 minutes with the 40 slides, each steps, what all the challenges could be, and in between my real world case scenarios. There was some discussion on why to wire all the time. I think mandatory, Dr. Bahulayan said all the time it should be 2 wires, insertion of 2 guide wires into each distal branch, starting with the most difficult branch to wire to be first. Once the most difficult branch being wired with a lot of manipulation, the next easy branch should be wired with a little rotation so that you avoid wire wrap. Keeping the wires separated, I think each people know how to do it. I generally fold it and keep it aside. And hydrophilic polymer wire shouldn't be used in order to avoid rupture of the jailed wire during removal. And when there is a demanding need to wire the side branch, unable to wire the side branch, these are all the choices one could have. In case of difficult side wiring, it is useful to enter the side branch by pulling back an angulated wire already inserted in the main branch, called pullback technique. And you can opt for a new hydrophilic wire with a good torque transmission like Cyan Blue, Fielder FT, like that. In some cases, a reverse wire technique also can be you make a loop and bring it back and drop it. And dual lumen catheters are definitely very useful to wire the side branch when you think it's difficult to cross side branch. As a last resort, one can also do block modification, like you do a part, that's part generally done after 10. You can do to start your case with also part. Just stop exactly at the carina in the pre-dilatation so that you make a way to the side branch sometimes. You can do a rotational atherectomy also if you think your calcium in the proximal main vessel is pretty impediment to your. Then coming back to the coming to pre-dilatation, pre-dilatation of main branch depends on operator's preference, and pre-dilatation side branch remains controversial because the bit, I think as of now EBC doesn't recommend routine pre-dilatation, but it can be done when there is a severe ostial stenosis, very calcified side branch, difficult to access side branch. With a small balloon, one can keep it open so that the potential, it is very simple. If you think potential closure of side branch is very huge, then you can do a pre-dilatation. Of course, why the EBC doesn't recommend routinely, it causes dissection, then it becomes side branch rewiring becomes messy and you end up in a additional stent. The very bottom line about provisional stenting is, it is a philosophy rather than a technique. So as much as you try your best to avoid a second stent. Crossover stenting is the way to go, and we know that when stent is decided as per the distal main vessel, that's what is routinely done. Then you end up in a proximal main vessel smaller position. Then if you don't address with the part, then it becomes an abluminal wiring, all that stuff. Contrarily, when you choose your stent to the proximal main vessel, then you overstretch the distal vessel, then you occlude the side branch by cardinal shifting. Probably in Arneja's case, it was sized to the distal, but was post dilated too much, so it has compromised the side branch. So let me take you to one of my case. I think one can agree here. There's a diffuse left main disease extending into the LAD. This is 110. There's a dominant, well-looking LCX without much disease angiographically. and both were wired, as said by Dr. Bahulayan, almost always. You need not see side branches, does it or not, you just wire it. And of course, preparation was done, as it was a very inviting case for a single stent crossover technique, as the side branch was disease-free absolutely. So we dropped in a stent from LM ostium to proximal LAD. Look at it here. This is the biggest benefit of keeping a wire in a dominant surg, even if it is non-disease. Of course, Dr. Goran Stankovic said that physiology in this context is still the answer is yet to come. So I didn't opt for physiology at this point. So went ahead with, there are people who have demonstrated this long, did nothing, and it came back. So one cannot take that bold decision when somebody sees such a pinching. So went ahead, distal cross, and did a kissing, and this is what it was looking like. So this is what it is. When you do a provisional stenting, a lot of concept with the sizing to the distal main vessel, part stopping at the carina, then even if the side branch get compromised, you can go ahead with the proper distal cross and kissing and repart, you can align everything back. This is a finally looking vessel. So side branch occlusions could be degree of side branch osteostenosis factors and side branch originating from main vessel stenosis, side branch reference diameter, stent artery ratio, stent implantation pressure, side branch main vessel angle, acute coronary syndrome, stent design, strut arrangement, geometry, and thickness. There is one resolve scoring which talks about disease at the bifurcation core, gross mismatch between the distal main vessel and side branch. There is haziness in the distal main vessel. The very oblique angle, and there is a critical stenosis in the side branch ostium. All that causes side branch potential closure. Clock shifting, we all know how it happens, and side branch ostial dissection, side branch vessel spasm, local thrombosis, stent strut obstruction, and carinal displacement, the main mechanisms. And Sridhar Kasturi told in one of the Arneja's case, keep the wire in the side branch, main vessel, aorta ostial lesions, and ostial lesions like ostial LAD. Do the Wolverine cutting balloon. Cutting balloon causes programmed dissection. This kind of intramural hematoma, unwanted side branch intramural hematoma could be avoided. And of course, we all talked about much about part. I just want to emphasize here, since the mechanism of stent enlargement is mainly represented by stent crowns straightening, a possible measure of this phenomenon is represented by stent crown ankle reduction, a parameter which has been found to differ among various tests. This is definitely need to be addressed. You can be highly skilled, you can apply all the concepts and techniques about provisional, but in particular day, if you have chosen a wrong stent, we come across this problem when we do it in scheme patients. Definitely, it becomes a challenge for side branch cross, kiss, all that. Instead of following all these steps meticulously, if you don't decide, select your design, dash design, like elite designs, like most multinational companies like Abbott and others, we sometimes get into some problems. Possible consequence of stent crown overstretching or the creation of variable gaps between the spreads, relating in impaired vessel wall scaffolding and inhomogeneous drug elution. This is what it is. When you keep and you do a non-post-dilated region and post-dilated region, when you keep a varied expansion of the drug eluting stent, the drug elution kinetic becomes different than the in ISR and whatnot. So this I will take you quickly. If the part balloon is positioned to too distal, then you cause distal vessel overstretch, distal main vessel overstretch, and you cause compromise on the side branch by pushing the carina, and also you cause malopposition and bottleneck at the proximal main vessel. When it's exactly stopping at the carina, then all the purpose are served. Malopposition of the proximal main vessel is addressed, distal main vessel overstretch is not happening, and the geometry of the main vessel is disturbed in a way the side branch access becomes better. When you keep your proximal part balloon too proximal, then you end up in a proximal edge vessel dissection, or you may open up the main vessel stent in a way the main vessel geometry alteration will not help you to recross the side branch. But Deepak was telling, however, you are sure you may not be able to, but we need to know. That's why the two wires all the time is going to help you. Where is the flow divider? Well, the case, because the LM will be a dynamic angle, keep changing, whereas non-LM will be a fixed angle, where the wire behavior, keeping an eye on this flow divider will exactly tell you where to stop your pot balloon, because stopping the pot balloon exactly at the carina will definitely serve the purpose. So this is the inadequate part when somebody extends proximal main vessel stent, but doing a part with a small balloon, then you leave an area of malopose proximal main vessel stent, then you becomes an abdominal wiring. All that, then you need to correct it with the reef balloon. For some reasons, if you are not at all able to cross a side stent, maybe you have to crush the proximal main vessel stent, then you may have to. So we need to know, even though all these steps are said and done, sometimes we may not be able to follow these steps meticulously for various reasons like clog burden, calcium, the amount of stent protruded into the main vessel. So we need to adapt immediately to your case situation and what you are going through in your steps, and then how you can bail out yourself. Only you will know and which step you went wrong. Regarding guide wire exchange starts by inserting the wire of stented artery main branch into the side branch, or by using the third wire. The third wire is always an option, but sometimes if somebody wants to avoid the third wire, apart the main vessel can be pulled and dropped to the side branch. Once made into an optimal distal tip shape and correctly oriented, this guide wire facilitates passage into the side branch to the most distal spread. When removing the jailed wire, this is what Stankovic was telling. Particularly in left main, when stent is placed at the proximal main vessel in the left main closer to the guide, when removing the jailed wire from the side branch, care must be taken to avoid guiding at the deep intubation using the left hand control in order to avoid deep intubation of the guide, which may lead to coronary dissection or stent longitudinal couples. So you do the part with the side branch jailed. Once part is done, what I do is the same balloon, slightly I blow it up, or just little bit cross and blow it. That will become an anchor, then pull the side branch wire. So the balloon which you used for the part with 1 or 2 ATMs slightly blown up, now allow the guide not to jump in and you remove the jailed wire. So another reason, another problems which can happen will be a jailed wire guide entrapment. This can happen while putting a guide wire in the side branch. This one can avoid hydrophilic wires, avoid placing the wire too distal into the side. You are going to jail the branch, way too much into the jail. Avoid placing the distal tip of the wire too distally and not to put into the secondary branches. You make sure it is traveled enough and parked in a very bigger lumen, and it's just enough travel down. While doing a main vessel stenting with the wire jailed in the side branch, avoid stent to oversizing. That happened in Arnaja's case. When it was oversized, there was trauma to the side branch. And check if doing the stent placement. This is the one. While doing a stent placement, we need to observe the side branch wire behavior. If the side branch makes an awkward shape change, then you need to adjust the side branch wire either by pushing or by pulling. Make it sure it is aligned in a more pleasant way to the main vessel stand. Otherwise, in that awkward position, you would have jailed, and by wailing it, it would have cut. This is one I have come across sometimes. While sending the main vessel, you need to observe the side branch, particularly when the side branch has an awkward angle. If it is taking a different plane of changing plane of the side branch, like happened in this pictorial diagram, one should readjust the wire position of the side branch. And similarly, when you are doing post-dilatation of the proximal part of the main vessel, again, avoid post-dilatation by oversizing. In case of, I think we need to select a properly sized balloon, adequately sized. I think imaging will help. I think we discussed this jailed guide wire entrapment. One can take a micro catheter or a guide closer to it and pull it back. In a worst case scenario, you can take even a small balloon through that in a case of not dominant LCX, which is causing a hemodynamic insult. When trapped wire breaks inside the coronary artery, surgery should be the last option. Most of the time, leaving a small tip of because the trapped wire snare will be very tough to remove coronary snare. You can just leave those pieces and cover them with the stent. They should not generally cause problem. Probably need to extend your DAPT arm for a longer period. We all know about this diagram, proximal cross, how it causes the main vessel deformity and lack of scaffolding of the side branch, whereas if the distal crossing is done, scaffolding of the side branch is also better and main vessel deformity is also no more existing. This is another case. I can tell you this is a bifurcation scenario everywhere. There is L6OM bifurcation, there is LM bifurcation, there is LAD diagonal bifurcation scenario. Bifurcation everywhere. So we wired L6YM, we opted for provisional philosophy that we just centered across the side branch and we went ahead with little protrusion into the LM. Of course, in LM bifurcation, it was two-stent strategy, whereas in L6YM, it is the provisional strategy. After stenting, we can appreciate there is a pinch, and we did it with a kissing balloon and fixed that L6YM in a provisional manner. Then we moved to the LAD. LAD was opted for two stents. After putting the first stent, of course, the second diagonal, that what Sri was telling about SNUH criteria, size, number, ubiquity, and height. If the numbers of diagonals are, I have 3 diagonals. So I was not very much serious about wiring that small. So size-wise, it is small. Number-wise, it is 3. So I thought I can take a chance on this diagonal. Then the second stent, of course, was dropped from LM to LAD across the earlier stent from L6, which was protruding just into the LM. And of course, the kissing was done and the second part was done. This is how it is looking like. So in a provisional philosophy with a kissing in the L6YM worked for me. The elective two-stent technique with the protrusion of ostial L6 stent into the LM with the final kiss worked for me. And those 3 diagonals applying the SNUH criteria, even though it was not protected in terms of size, number, it was flowing. Even if it's occluded, I was not worried because other 2 diagonals were there above. So this I think we have discussed already. Failure to advance. This happened to me twice. What I generally do is use a lowest profile, one balloon or anchoring balloon technique. The distal main vessel balloon, I blown it up and take the balloon. Now I do the repart again. This happened recently to me. One, it happened for wiring. Repart allowed me to wire. Once it, balloon was not going, then again I did a repart exactly at the carina. This time the balloon got in. And sometimes rewiring the main branch to correct the wire up. We never know while this manipulation, the main branch wire would have wrapped. If just pull it back and rewire, things may be solved. We know the disordered aggressive kissing, which was done by Stankovic, discharge the proximal main vessel. Long balloons will cause proximal overextension, cause geographical mess. Semi-compliant balloons at the ostium side branch will cause dissection. And this is being discussed. Once you have compelled to put an additional stent in a provisional, if at all that philosophy didn't work for various reasons like spasm, dissection, lesser semi-flow, all that, then you need to convert it as a T-tap or ocular or reverse crash. This is my final case. Sorry to take you little extended time. This is again, I just wanted to live up to the question of Dr. Deepak Davison. When he called me over the phone, he wanted me a real bad case of my provisional stenting. Unfortunately, I was not able to get it. But this case, it looks like a simple case. Forget the LAD. You can see there is a LCX discrete lesion involving both the OM as well as the LCX. Wired the both. Of course, it was decided for provisional because the side branch lesion length was just not more than 5 mm. Stented across the side branch. Kissing was done. This view looks okay, but I will show you one view. Are you able to see in this LAO awkward caudal projection? You can see there is a minute dissection on the top of the side branch with an entry flap seen and exit flap not well seen. Everybody agrees here? This angle of L6 OM was very, very awkward. So if I would have opted for additional stand for this minor dissection, in long term, I would have compromised the result of the main vessel. So after careful assessment of this particular dissection, non-flow limiting, very minute dissection, considering the very awkward angle of the L6, by such an oblique parallel takeoff, I thought I will do nothing for the side branch. So sometimes, hope I answered Deepak's question. Sometimes when you want to really give so much importance to the main vessel, after applying all the criteria of how much the side branch is important, sometimes doing nothing for the side branch also sometimes an answer, but not in a case like dominant L6 serving a bigger myocardium. But I thought in this case, as it was non-flow limiting and it was very, very awkward angle, I thought I will not do anything for the side branch. Thank you, one and all. With this, I stop sharing and hope I served some purpose for the for Deepak Davidson, keeping it as a provisional and challenges.
Thanks, Shivama. That this is exhaustive, really exhaustive. We have covered the whole 3 hours session in one talk, I would say. Thank you very much.
Thank you, Bhagalain sir. Thanks, Sri, and thanks, Vijay.
Shiva, at least one question to you, Shiva.
Please.
Shiva, regarding your all bifurcation case, you had a circumflex OM bifurcation, which you decided to treat as a provisional strategy. And when you deployed the stent inside the main vessel, you positioned the stent in the circumflex ostium. Probably it was protruding a millimeter into the left main. Is that so? Was that intentionally done, or you converted the strategy of left main bifurcation into a mini crush? Was that your thought? What exactly was your thought in your mind?
I think this was earlier. I'm getting into this concept of. I think I was talking about. I don't know what Dr. Bahulayan and Sridhar Kasturi will be reacting here. See, we all telling about the provisional technique. Why that provisional philosophy came in all way? Because why the criteria of side branch lesion length within 5 mm? When you do a part, there is an element of main vessel strut going and scaffolding the side branch mouth. Hope everybody agrees to this point. Now, when you put a side branch stent and when you protrude with a little very, very nano protrusion, I am damn sure that I agree with the Deepak Davidson. There will be an area of triangle which will be spared in the side branch ostia. But my point here is, when you do a part of the main vessel after this, anyhow we have to do a part, there is some element of stress going to fall. Now, your side branch stent, which is very precisely protruded, which can be done with your OCT also. Now, even if there is a very minute gap, now I am damn sure it is going to get covered by your meticulous part sized to the proximal main vessel. Of course, I am trying to do with the help of seniors here. Dr. Bahulayan is here. Vijay Kumar is going to give us a backup, and great clinical operators like Sridhar Kasturi and Deepak Davidson here. See, Garan Stonkovic mentioned, he mentioned the Korean bifurcation club, Japanese bifurcation club. He never mentioned Indian bifurcation club. Is it because we don't get into a common platform and design our own way of dealing? Our colonies are certainly different. I think this kind of series will take you to the next step, Dibu. We need to come to an understanding how we will be treating, what is our consensus on producing papers. There is a core lab with Vijay Kumar. Coming back with our data, why not precise, having done imaging, why not precise ostial positioning and doing a part and make sure there is nothing spared now. If at all Deepak Davidson concern is still an ostium of the side branch is spared, I'm damn sure with the proper part, precisely positioned side branch ostium, I'm just claiming maybe it is an angle to angle, it may differ. Until otherwise someone does a series of cases and exercise, I may not have an answer for this.
Shiva, good thoughts, Shiva. Vijay, your thoughts on this?
Yeah, I think everything has been discussed already, sir.
It's too much time. Deepak Davison kept me the last.
No, Shiva. You shouldn't feel bad, Shiva. One more
No,
point we'll
I
discuss.
think you create a lot of interest. That's why your
Yes, Shiva,
talk
it
was
is
kept
good.
long.
Shiva, you mentioned that while doing the pot, you would always have a jailed wire by the side, right? Is that so? But at least two situations shall I put forward. When you have a long segment of vessel to be wire to be jailed, and second situation when you have a calcified segment to be jailed. So when you have a calcified segment wherein you want to have the wire jailed, would you at least think that there is a small possibility that you might have a challenge in retrieving the wire from the sideband? Because this happened to me around a month ago. We were committed to a ultra low contrast, a calcified vessel in a mild CKD patient, and we had the wire inside the side branch, and the following part the wire wouldn't come back. We were very fortunate that even a 1 millimeter balloon wouldn't go by the side to push it in by between the caged wire and the stented segment. It wouldn't go in. Ultimately, with great force, we had to pull it out, and it fortunately came out. And by the time, one important thing that we did was we already had a balloon inside the LED, so that when we pulled out the balloon from the side branch, when we pulled out the wire from the side branch, the guide catheter, it jumped in and it hit the proximal stented segment, and there was some deformation of the stent. So we were fortunate that we had a balloon inside the LED. We could appropriately dilate the balloon, and we could salvage that particular situation. So would you always say that you will be a fanatic always having a wire inside the side branch when you do a pot, or are there any situations wherein you would always pull it?
What I am telling is for left main, because left main, the proximal main vessel arm is very maximum 20 mm. So it is for the left main where it is mandatory for. Yes, I also happened one case when you do a rota in the proximal main vessel and we make cracks in the calcium, and your side branch happened to be an Oxford wire. Definitely there will be a well in the wire, as well as there is a crack, you will get caught. So as rightly said by Dr. Siva Prasad, this concept of provisional is more applicable when it comes to left main, where at any point of time you are going to jail only the part, very 30% of the wire. But of course your point is very valid. If it is a mid LED diagonal where the LED and diagonal was very densely calcified, now you want diagonal and the proximal main vessel, the proximal LED above the diagonal is pretty long and you jailed, then it is tough to pull out the wire. I think the calcium post-rota, these are the situations. If it is proximal main vessel is a long jail, I may not jail it. Otherwise, it is mandatory if it is left main for the side branch. Side branch is significant. Proximal main vessel is small, and it is a huge vessel, so it is naturally going to come out.
One more small question, sir. When there is a very difficult situation where you have to pull out the wire and you expect to have some issues, one good thing is you keep the balloon in the main vessel. That is, do you always use a microcatheter for the side branch where, suppose if it unravels, so at least the whole thing will be inside your microcatheter rather than freely floating in the proximal main vessel?
As you rightly said, first thing you can do is take the balloon in the distal main vessel, anchor it, and try to the wire. While try to pulling the wire, the guide will also go and reach the side branch ostium. Gently still try to pull it out. If that doesn't happen, then take the microcatheter. So by the time when you are anchoring the balloon, when guide is going closer to the side branch ostium, now still the balloon is not coming. That means microcatheter option is kind of a philosophy has been already tried, because the guide catheter is acting like a microcatheter now. Now you need to take a call. If it is not going to come out, then you need to take a small balloon abdominally in the jailed wire and push it aside, then put the wire again into the cross and remove this wire. So I think you need to have that feel, a tactile feel, and take a call. If you are not doing the distal anchor balloon, maybe you can take a microcatheter. But I don't think, I have tried once. The microcatheter will not go easily in that part vessel into that stretch.
No, I'm not talking about taking microcatheter inside. Suppose there is always a small risk of wire unraveling when you pull out with
okay, right.
So even if it gets cut, I think it is better to have it inside the microcatheter rather than freely floating.
Yeah. When you get caught, take it to the as much tip as possible so that you can remove the end slot.
Even it gets cut, so there is a chance of sometimes we had once it is the whole wire was unraveling in aorta. So
perfect. Now I got the point. When it got in becoming unravel, take the microcatheter closer so that it will not get cut. You can remove it back. Yeah, got it.
No, Shiva. The point is different. What he was trying to make was something similar to a jailed balloon. Rather than having a jailed balloon, just keep a microcatheter there when you deploy the stent, so that when you want to pull it out, it would easily come. Was that what you are trying to?
No. Not this. Suppose you jail the wire, and it is difficult to remove it. You tried all the
but still there is a connection.
Fully, and sometimes when you pull it forcefully, you can go jam the dead stent, another thing. But most important thing, sometimes the wire can unravel. All this, your whatever you call it as spring.
Now, if you still continue to remove it, you are going to cut it. Now, at this point, he is telling us, this came to me
and if something happens like this, if support get cut, and most of this unravel part will be in your microcatheter rather than inside the proximal vessel or in the aorta.
Yeah. Shiva, thank you. Shiva, thank you. I hope your session was good. Your presentation was good. Everyone enjoyed it. We had a reasonably good discussion.
Right.
Shiva, thank you so much. Let me take the opportunity to thank all speakers, all panelists, and all everyone, including moderators, for being with us today. Vijay, thank you so much once again. Hope to meet you all tomorrow, because tomorrow we're going to discuss more on DK Crush technology. So we'll start at 7 o'clock tomorrow. Thank you so much, and good night. Take care.
Wish you good luck for our next 2 days of the series. All the best. Thanks, Vijay. And I'm going to see both of you in my upcoming meeting. Thank you. Bye-bye.